the old Supreme Court chamber. This is where the Senate Public Health and Welfare Committee, which I chair, meets. And it's where the Finance Committee, which Senator Harkins chairs, meets. But as everyone knows, this room does not belong to our committees, and it certainly does not belong to us. It and this Capitol belong to the people of the state. They can be proud of their Capitol, and they're welcome to come look at it anytime they want to. We're here today for a joint hearing about ibogaine. Senator Harkins has expressed an interest in this for a good while. So Senator Harkins is up here, is basically going to act on behalf of the Senate. And of course, my counterpart, Representative Sam Creekmore, who chairs the Public Health Committee in the House, is here. And at this point, I'm going to turn the meeting over to Chairman Creekmore and let Senator Harkins represent the Senate insofar as we need representation at the hearing. And I'm going to sit quietly and listen. We'll see how that goes.
The odds on you sitting quietly and listening and staying quiet are very slim, Senator Bryan, but thank you. And good morning, colleagues, stakeholders, and members of the public. Thank you for being here today for an informative hearing on the future of healthcare and recovery of our state. I want to thank the Mississippi Senate for allowing us to use this room, especially recognize Senator Bryan, who was gracious enough in his support, and acknowledge Chairman Josh Harkins of the Senate Ways and Means. This issue is deeply personal to him, and I appreciate his partnership in helping make today happen. We're here to consider ibogaine, a naturally occurring compound gaining attention across the world for its potential to treat opioid addiction, substance dependency, and post-traumatic stress disorder. Like the rest of the nation, Mississippi continues to bear devastation in the opioid epidemic. Entire communities have been scarred, families shattered, and too many lives cut short. On top of that, we face a growing mental health crisis that weighs heavily on our veterans, first responders, and trauma survivors. We know the truth that current treatments, while essential, are not enough for everyone. Our responsibility as policymakers is not to embrace new solutions blindly, but neither can we turn away from credible science or from testimony from those who found hope where hope seemed lost. I want to acknowledge that today's hearing will include powerful and at times deeply personal stories. Some of our witnesses have come from across the country to be with us and share their experiences that are difficult and raw. I want to ask us to listen with respect, compassion, and especially open minds. Let this be the beginning of a serious and honest conversation, not just about ibogaine, but about how Mississippi can think differently in order to save lives, families, and lead with both courage and compassion. We've allowed 15 minutes per witness, but we understand that some stories may take a little longer, so we'll guide by discretion. So we're ready for our first testimony, and that will come from, and if you would briefly introduce yourself, Mr. Miller, and you're good to go.
Hello, everyone. My name is Trevor Miller, and I am here because I have been providing this medicine called ibogaine for the last 15 years in various different capacities. But it is an honor to be here. What I will do my best to do today is give you a high-level understanding of ibogaine, how we're operating currently in Mexico, and perhaps suggest a few different paths forward. It's a very exciting time, having been involved in working with this very obscure medicine for the past 15 years, to now be in a room like this esteemed building. It's very emotional, actually, because I've seen you can almost call them miracles that this medicine has accomplished. And to be here and see bipartisan support, whether it's here, whether it's in Texas, across the United States, it's just great to be here. Thank you for the invitation, Chairman Creekmore and Senator Harkins. And today, throughout the entire presentation today, whether it's me or anyone else, we'll do our best to share evidence and whenever I'm in front of an audience like this, I just want to paint a picture on what the ideal could look like moving forward. I'm Trevor Miller. I'm basically here because I've been providing this medicine for some time. I was able to legally do this in Canada, where I'm from 2012 through until 2017. And then Health Canada changed the regulatory status of ibogaine, so I haven't been able to work with it there since. But through this work, I was introduced to Amber and Marcus Capone, who started the nonprofit Vets Incorporated, who have been sending U.S. Special Forces veterans for this treatment. And after that meeting, we quickly moved towards setting up in Baja California, in Mexico, where we could provide this medicine legally as well. I like to call out the elephant in the room. Ibogaine is what is termed a psychedelic. Psychedelic has a bit of stigma behind it, of course, but if you really look at the word literally, psychedelic means mind or soul manifesting. Psyche is the mind, or soul is technically the first in the Oxford English Dictionary is the first definition for psyche. And then the delic comes from delos, which is Greek to make manifest. So psychedelic means mind manifesting. And if anything, I think that's an accurate description for what these compounds can do. They bring about a different level of mind. And I think it's crucial to note that up until before the late 60s, early 70s, cultures all around the world use these compounds, and they were always deemed pro-social. They were used in communities for healing, for betterment, for initiation, for making society stronger overall and communities stronger overall. And indigenous communities have been using these for centuries, and even Western culture. Greek culture had what was called the Mysteries of Eleusis. It was a 2,000-year-old tradition. It was considered the most important aspect of Greek culture, and we now know that there was a potion included in the Mysteries of Eleusis that it was called the kykeon. It contained an LSD type substance in it. So much of our Western culture, our democracy, our education system grew out of the genius in Greek culture. And I don't think those Greeks ever intended that psychedelic experience to be separated from the rigid structures that they were building. So that's just my hypothesis, but it's something worth considering. It's only in the late 60s, early 70s that these substances were deemed antisocial. So this is brand new. And sadly, when these substances were outlawed, so was the science around these substances outlawed. And the only other time that science has been outlawed in the history of the modern world was when Galileo said that the sun was the center of our solar system. That science was then outlawed for more than 100 years. So it's super sad that the science was outlawed along with the substances. But we're here specifically to talk about ibogaine. Ibogaine is a plant medicine. It comes from a plant called Tabernanthe iboga, which is native to Africa, countries like Gabon and Cameroon. Cultures called the Bwiti tradition grew out of the use of this medicine. Again, they have been using this medicine ceremonially for centuries in pro-social ways. The pharmacology engages multiple neurosystems. It supports mood. We've seen it reduce pain in great ways, and it does a reset on cravings as well. Clinical use today is as an addiction interrupter. It helps with trauma-related conditions, and emergent evidence is showing, and we've got a neuroregenerative program at Ambio now as well, which shows that it's greatly helping with conditions like Parkinson's disease and multiple sclerosis as well. It's got multi-system healing. It affects many systems within the body. It affects serotonin, dopamine, the opioid receptors. The ibogaine experience itself is called oniric. So oniric means as related to dreams. So it's kind of like a waking dream type situation. It is visionary, potentially. It is not enjoyable. There is a very low chance, I would say a 0 chance of abuse with this compound. It is a long experience, anywhere from 24 to 48 hours. It comes with nausea, ataxia, which is a great shaking reaction to the medicine. But yeah, it is not fun, but it does seem to come with a deep reset. The word reset comes up quite often with this substance. It's emotionally cathartic, mentally clarifying, and results are typically achieved after just 1 dose. Ibogaine does require medical oversight. It is potentially dangerous if not used properly, but that shouldn't scare people away. We do know how to safely give this medicine. You get EKGs ahead of time, blood work ahead of time. You get coached on how to come off what medicines and what medications you might need to come off of. We boldly call ourselves at Ambio the global leader in integrative ibogaine treatment. And we are technically the most experienced ibogaine providers out there. I have 2 business partners. They each have 15 years experience as well. We do have different programs for detox. So ibogaine is very good, as you've heard, at helping people overcome opioid use disorder, other addictions. We have our foundational program, which is a 5-day program that has really grown up around our treatment of veterans. We have this neuroregenerative program, and it also mentions there that we have multiple papers published. One of the most recent papers we published was just a case study on multiple sclerosis with brain scans that showed that the MS lesions after ibogaine reduced in size by 71%. That gentleman no longer shows any symptoms of multiple sclerosis. Ibogaine care and safety is very important. As I've mentioned, we do blood work ahead of time, EKGs. We are fully medicalized. I think we have more than half a dozen doctors on staff right now, endless amounts of nurses and paramedics. I think our medical staff is upwards of 50 people now. We have full medical supervision. We have 5 clinics that operate in Baja, California, 1 house completely dedicated to detoxing, 3 houses where we work with this 5-day program, which is shown so good for veterans and first responders and traumatic brain injury. We do it in a group treatment format, and we provide lots of post-treatment support as well, which includes coaching and weekly support groups. We have, in the 4 years we've been operating in Mexico, treated upwards of 2,500 people. At least 1,500 of those were veterans, more than 1,500 with veterans and first responders. We treat complex cases, including TBI, PTS, chronic pain. We are completely medical supervised, as I've mentioned. And we have the good fortune of working with some incredible nonprofits like Vets Incorporated, as well as the 343 Fund, which sends first responders to us. We were the site for a study that was conducted in conjunction with Stanford University. So 30 Special Forces veterans, they all needed a traumatic brain injury in order to get into the study. They went to Stanford prior to coming to Ambio for our protocol. They got brain scans, a battery of other tests. They came down just for 1 dose of ibogaine, then went immediately back to Stanford for more brain scans, more follow-up. Then there was another test a month out, and the results were incredible. The brain scans beforehand clearly showed traumatic brain injury. Post-brain scan showing that it was largely reversed in most of these guys, if not entirely reversed. It's the first human evidence of structural brain regeneration from ibogaine. The brain changes were still present a month later. I know it's been more than a year now. They're still present. PTSD, depression, anxiety scores went from almost off the charts down to nothing, and that had lasting changes. The incredible result for me on this one, is the traumatic brain injury. So they do a measurement for the traumatic brain injury. Immediately following the ibogaine, so less than a week later, there wasn't that much change. But a month later, all of those scores had dropped dramatically. So ibogaine stays in your system, continues to work and do good stuff within the system. And the subcortical volume here, when we talk about neuroplasticity in the brain, we're talking about the gray matter. And we know that the gray matter in the brain can change and does change. But this is the first time they've seen evidence of anything increasing the white matter in the brain, which is kind of the main superhighways of the brain, and the volume increased there. There was a new study out of this, a new paper published out of this study. This was just published about a couple of months ago, and it measured the EEG, the brain waves after ibogaine, and the brain waves after taking this medicine changed into brain waves that are the equivalent of had somebody been meditating for a long-term meditation practice. After just one dose of this medicine, all of a sudden those brain waves drop down as if somebody had had a long-term meditation practice, which is quite astounding. The opportunity here is rich, whether Mississippi teams up with Texas, allows Brian to spearhead initiatives across multiple states, whether you dig deeper into the Right to Try program, which has been successful here in Mississippi for perhaps even earlier access to this medicine. And Ambio and my entire team are here to help any step of the way. Again, it's a big honor to be here in Mississippi. And I'll again say that as we move forward, let's just start with the end in mind. This is not a brand new molecule that we're inventing from scratch that we need to take through the clinical trial process just to figure out how to properly use it. We know how to properly use this. We've been using it in naturalistic settings for decades now. We've got tons of scientific evidence on how to do this properly, how to do this safely, and how to do this comfortably. We can skip the steps where somebody is alone in a sterile hospital environment going through this experience without the support, comfort, and love that people feel when they come to a clinic like ours or some of the other ones that are located down south. But it has been a real honor to be here. I hope I sped through my time good enough. And again, thank you so much for having me.
Thank you, Mr. Miller. We've got a few questions, but
Sure.
all right. And your clinic's in Mexico,
Yeah,
and you've been open for how long?
we've been operating down there for 4 years.
All right. In those 4 years, what percentage of Americans are veterans that are come to be treated
Percentage of Americans would be 99 plus,
that are veterans?
and veterans would be about 70 to 80%.
And
The
does that
bulk
include,
would be Special Forces veterans as sent through the nonprofit.
does that include first responders as well?
Yeah, first responders that number does include first responders. It's around that 70 to 80%, including them. And that's a remarkable population to work with, because veterans, they get to go home after deployment. First responders see it day after day after day. So they're almost more severely traumatized when they come down.
And can you put a number to that instead of percentage then? How many first responders and veterans?
We've treated around 1,500 combined. First responders, not as much. That's kind of a newer pipeline, but I'd say at least a couple of hundred first responders.
And your success rate?
It depends on what you're measuring as your level of success. It's safe to say that overall benefiting a human being, ibogaine has close to a 100% success rate, because maybe let's take a look at addiction perhaps. Is abstinence the measure for success? Well, then ibogaine doesn't necessarily have a 100% success rate, but did that person get something spiritual out of the experience? Did they see that there is potentially a way forward? People do relapse sometimes after ibogaine. I have never met one person who said it's because ibogaine failed me. It's more that they didn't have the support and they didn't take use of the opportunity that Ibogaine presented.
Senator Harkins?
So I think my colleagues and I believe I'd speak for most of them when say, you know, the measure that we want to make sure we achieve is that we do no harm. And I think that's the thing that we constantly dwell on when we're up here making decisions. And I think I resort back to when we passed Harper Grace's law several years ago, which now seems kind of the product we're talking about seems significant with the steps that we've taken over the last several years. But I think UMC had proposed protocols and they had done some preliminary measurements to figure out what dosage to give and all that type of stuff. Can you speak to like how y'all establish your protocol on how to dose, how to, you know, basically treat the patient? And I'm not asking you to tell on yourself, but have you had any experiences where people have had, you know, adverse effects from Ibogaine, or has it been pretty
It
pretty
is so easy
non-significant?
to screen out the adverse effects. So, you know, dosage wise, it's milligrams per kilogram of body weight. So it's not rocket science, quite frankly. And then it really isn't rocket science around keeping this safe as well. There's very little mystery. I would say no more mystery in how to do this safely. It needs to be medically supervised. You need to, you know, do EKGs ahead of time. You need heart monitoring during the treatment. You need blood work before, after. And if you do that, the chances of adverse events go down to next to nothing.
Okay. Thank you.
Senator Wiggins?
Thank you very much. I have two questions. So first is, I think I heard about it, but just want a little more detail. So is this used in addiction treatment and prevention? We've had tremendous success with drug courts in this state. The demand probably outstrips the supply right now. There are different philosophies on how to treat addiction. So can this be used for that?
Yeah, the initial kind of miracle that was discovered around Ibogaine was in 1962 when somebody who was severely addicted to heroin took Ibogaine, went on this incredible journey, but came out the other end and said, wait a second, I haven't wanted heroin the whole time I've been on this, nor do I want it now. So without going through those epically painful withdrawals that can last months, even years with post-withdrawal symptoms, Ibogaine is a incredibly powerful negative pattern interrupter. The thing I'll mention though, because you mentioned drug courts, is I think it would be extremely unethical to force somebody to take something like Ibogaine. It is,
Yeah, we don't. No, I don't know that we do that.
No, probably, yeah.
But there's alternatives for treatment. Treatment is the point.
But I think making it an option to somebody coming through a
Right.
drug court, give them informed consent, and then allowing them to make that decision, it would be incredibly powerful.
Well, let me rephrase that. Pete, there is in that space, people only like at times the tried and true, and we need to be looking at other things is my point. And then speaking of that, so my other question was, you mentioned that you were in Canada and then they had a regulation change and you're in Mexico. So there's a regulatory scheme, whether people like it or not. And you also mentioned there's support the science. So what is the status of it being allowed in the country? FDA, why did you have to leave Canada after they changed the regulatory scheme?
Yeah, so in Canada, Ibogaine was listed as a natural health product. When they created the natural health product scheme in Canada, I think Ibogaine just happened to be on a spreadsheet that they uploaded. But the natural health products are things like supplements that are available over the counter, vitamin C, that shouldn't be potentially dangerous. Ibogaine, as we've discussed, is potentially dangerous if not used properly. So it's not something that should just be available over the counter, although it never was. But Health Canada realized that they had misscheduled it and they could have made it illegal. Thankfully, they didn't. What they did is they put it on the prescription drug list. So because it still hasn't gone through clinical trials, it's not available as a prescription. So it's still in that no-go zone. But it's at least in Canada, it's not Schedule 1, the equivalent of Schedule 1. So it's easier to research in a place like Canada. And we have a university in Canada that's doing a bit of research for us as well.
Well, so that's my question is, so is it, it's not is it scheduled in the US? Is it,
Yeah,
is it a narcotic that
in-
has to be overseen by a physician?
It's Schedule 1 in the US.
Schedule 1,
So
okay.
there's irony in that because Schedule 1 is there's a high potential for addiction and there's no medical benefit.
Right.
Where Ibogaine is anti-addictive and has tremendous medical benefit. So I think if there's any drug on Schedule 1 that is misclassified, it is Ibogaine. It needs to go down a few notches for sure.
I may open up a Pandora's box here, but I don't want to, but so why hasn't it been rescheduled on the federal level?
I think it's just challenging to reschedule a drug on the federal level. I think there's a lot of potential. I've said for years that Ibogaine needs a magic wand, and it seems like there's some magic wands laying around right now. I know that Robert F. Kennedy Jr. Ibogaine is on his radar, and that's what I would suggest is the lowest hanging fruit for doing
if you're
change.
I'm sorry, I wasn't going to get into that, but if you're going to bring up him, he's a skeptic, and I'm sorry, there's a lot of his vaccine skeptics is
Yeah.
ridiculous.
Yeah. I'm just
And,
saying
and
he's a man who's
this
in-
stuff, so
He's
I
just
wouldn't
a-
put him in that, in
He's
that
just a
category.
man who has the potential to reschedule is all I'm saying.
Correct.
Yeah.
And then my last question is, and this is the problem with the regulatory, is we've seen it in different ones. It puts our law enforcement in a predicament where it's scheduled and not allowed as a Schedule 1 on a, on the federal level, and then the state allows for it. And then law enforcement's like, what am I supposed to do? And then they're like, well, I'm supposed to enforce the federal law, but then the state law, we can have it. And so we're in a regulatory scheme that puts our law enforcement at risk. I mean, and if I think when I hear this, I say we ought to be doing this, but then I also think about like, okay, if we allow it, then it's a Schedule 1 and our law enforcement's caught in the middle.
Yeah, I think the path forward is through the FDA. As there is a path forward to research Schedule 1 drugs through the FDA. So that would get the federal approval, the state approval would come with that. So there, nobody here, I don't think, is suggesting just blanket decriminalization of Ibogaine. And that's states like, there are states that have done that, and that creates the dichotomy exactly like you just suggested. But I don't think anybody here is suggesting that.
All right, Mr. Miller,
Go
we
through
want-
the FDA process, we're good.
Gotcha. Thank you. We want to, got a couple other questions. Senator Blackwell?
Thank you, Mr. Chairman. In your, one of your slides, you had some of the benefits that the patients were receiving. And I think one of the slides talked about improving memory, focus, and processing with the brain resetting.
Mhm.
Have you done any studies with Alzheimer's patients to see if this, they would be beneficial, or if this drug would be beneficial for them?
Yeah, the question reminds me, another point that I didn't point out on the Stanford study is they took those brain scans, ran them through an AI algorithm before and after, and determined that the age of the brain went down by an average of those 30 guys was 1.37 years. So it actually affects brain age. We have, my theory with Alzheimer's and dementia is that it's not going to be great for late stage Alzheimer's. And a big reason is the informed consent. People need to know what they're getting into when they take something like this. And I've worked with some later stage and didn't see that great of an improvement. I think if you were predisposed to dementia or Alzheimer's, and you took Ibogaine early enough, your chances of developing the disease would go down. And I've got an N of 1 example of that where a gentleman, a veteran, He had traumatic brain injury. He went to Walter Reed. They said that you have early stage dementia. You need to come back to us for a workup once a year for the rest of your life. After taking Ibogaine, he went for his 2-day, 10-hour workup. They said you have no signs of dementia anymore, and you're scoring higher than average now. You don't need to come back anymore.
Thank you. Ms. Scott has a question, and while she's getting the microphone, what does it cost to have a treatment at your clinic right now? One treatment.
It's about $8,000.
Okay, Ms. Scott.
5-day treatment.
Thank you so much, Mr. Chairman. I want, some of us are interested in how it affects addiction. So in Texas, this is a clinical trial, right?
Yeah, that's what they're moving towards, is a clinical trial.
Okay, can you describe it? Can you tell us what the population is in the trials?
I don't think
Okay,
it's been determined yet.
Ms. Scott, we'll get into the Texas trials later. We got another,
Yeah.
no, you're good. That's a good
Yeah.
question.
Okay, well, that's.
Thank you, Mr. Miller. Thank you for your
Good.
testimony.
Thank you.
Next up, we have a good friend of ours, Dr. Tom Recor.
It's good to see you all again. Thanks for having me. Senator Harkins brought up a fantastic point about do no harm. And I think that's what I think about most when I'm contemplating whether a novel treatment makes sense for us to pursue, or how we want to conceptualize what it means for someone to be mentally well. So today I'm just going to take a couple minutes to go through sort of the more recent history of psychedelics. And today I want to spend just a little bit of time on the current state of psychedelic medicine in the country. What, not just Ibogaine, but what we've seen occurring in open label and some other trials. So in the 50s and 60s, early researchers discovered that LSD and psilocybin could be helpful in alcohol use disorder. To be fair, it wasn't just the war on drugs that resulted in some criticisms of how those studies were done. You can imagine if I, as a psychiatrist at the state hospital, gave some of the medicine to my patient and then took some of the medicine myself, and we just wanted to see how it all went down. So some of that wasn't well done. And then in the 70s, with the criminalization era of controlled substances, psychedelics, all psychedelics were listed as Schedule 1. You see that I skip here to 2010 to 2020. That's not to say that nothing happened in the 80s and 90s. MAPS, you heard about the Multidisciplinary Association for Psychedelic Studies, started in '86. They've been instrumental in pushing the FDA to open its mind to possibilities that psychedelic medicine can offer treatment. But really, since 2006 at Hopkins, there's been a significant increase in interest in these substances. So we've discovered that psilocybin studies show significant benefits for many mental health conditions. FDA designated MDMA and psilocybin both as breakthrough therapies, and we're seeing some of our top institutions here and abroad leading research on psychedelics. These are, we just spoke about this. Oregon has legalized, which creates, Colorado has also legalized supervised psilocybin therapy, which, as Senator Wiggins pointed out, can be problematic. Australia has allowed MDMA and psilocybin for prescription use only. And then, as you'll hear today, Texas and a few other states have funded research, especially for veterans with PTSD. These are clinical outcomes. So the first we'll talk about in this category of psychedelics, we're thinking about psychedelics in addition to Ibogaine being psilocybin, MDMA, DMT, LSD even. And so these are a few of the clinical outcomes that we've seen. A study at Hopkins in New York, terminal cancer patients experienced significant reductions in anxiety and depression through a one-time psilocybin dose, and those benefits lasted 6 months. We're thinking about harm on the front end. You're talking about folks at end of life. I don't know how many of you sat with someone at the end of their life and experienced the sort of emotional challenges that come with that. And these studies themselves demonstrate pretty significant reduction in some of the suffering that goes along there. Hopkins showed psilocybin-assisted therapy reduced alcohol use, resulting in a 50% reduction in heavy drinking days. This really, for me, goes beyond just the effect on the individual. I don't know how many people here grew up with family members, what you would have given to see a 50% reduction in your caregivers' heavy drinking days, what that would have meant for you. But it's not just the individual. We're talking about iterative effects. And then smoking cessation, for any of you who have ever tried to stop smoking, a single dose benefit can be helpful. Some of you are familiar with the MDMA studies, significant benefits in PTSD, and then the FDA in 2024 decided to not endorse MDMA because of, frankly, they were fairly critical of study design and blinding, and that's a good sign that the FDA is paying attention to all of this. And you just heard Trevor talk about the Stanford studies. One of the things I don't know that he mentioned, but TBIs are pretty intractable. The sort of the benefit that was seen in this trial is like nothing else we've got available in modern medicine. Fundamentally, most of these guys weren't diagnosable with a condition afterwards. Now, there's obviously issues with things being open label. So you have this cohort of special operations veterans that really want to get better, that meet with these really smart folks, and then they go to Mexico and receive Ibogaine in this therapeutic environment. So can we match the outcomes here in a place that's not Ambio? That's yet to be seen. But in the current schema, this is a Schedule I substance that has no possible therapeutic benefit. It just seems to me that there's a possibility here that there's a signal we could investigate. So this is the last piece I think I want to talk about, and this is a conceptualization of how these psychedelics work. So the default mode network is how our brain operates in a state of rest when we're not concentrated. So an unconcentrated mind, you think about daydreaming, self-reflection, thinking about the past or future. This is what we're doing when we're driving to and from work. This is what we're doing in the moments before we pick up our phone and doom scroll. And it includes regions of the brain that really are immaterial for this conversation. And the DMN is hyperactive in depression, anxiety, and PTSD, especially in patterns of negative self-referential thinking. So you can think of the DMN as being a storyteller. So this operates in the background of your mind, and you can imagine a scenario where we'll call a gentleman Eric, that he grows up in imperfect home situations. I don't know if any of you know of any imperfect home situations, but maybe inadequately supported as a youth, and is plucky and works hard and decides to take on one of these really difficult careers like special forces, or we'll just say in this case, Eric is a trauma surgeon. And the way he copes with some of his life's challenges are by overperforming. So he's going to be the best trauma surgeon. He is the best. If you or your family is struggling after an accident, he's the guy you definitely want to see. And over time, Eric comes to believe that because he's had failures at work, that maybe he doesn't deserve the accolades he gets for being such a hard worker and so good at his job. And he's missing home, so he comes to believe that he's not a good parent and doesn't deserve to be loved, and he's not a good dad. So what's the point? So his story, the default mode network, will just tell his story to him over and over. And what may actually be true with a change of perspective is that he's an imperfect person like all of us. He does the best he can under the circumstances and deserves to be a person who receives love in his life. And it's not to say that that's what any of these psychedelic medicines do specifically, but when the default mode network is interrupted, these different perspectives become available for people. And that seems to be, for me, the best way to understand what happens and how psychedelics can be helpful. And it's by disrupting rigid patterns and allowing for new perspectives. Okay, so really for me, the question isn't whether ibogaine is the thing that will cure all of these serious conditions. And we're not talking about, someone having a case of the Mondays. We're talking about opiate use disorder. And we know where that ends up when it's not headed in the right direction. And we're talking about things like TBI, which TBI and PTSD can be exceptionally disabling, right? And so the question isn't whether this is the thing. The question is whether there's enough of a signal for us to pursue research so ibogaine can do the work it either can do or can't do against current standards of treatment and against other medicines in this category. I think, so this is Tom Recor's opinion, I think there's a clear signal that these medicines can be helpful to people, and the conditions we're talking about treating are extremely high risk conditions. And so the question for me is it worth continuing to pursue more data before we make a decision? And the answer for me is a clear yes. So that's all I'm going to say, and I want to be available to any questions if you have them.
Senator Bryan?
The FDA and Schedule 1 are only effective in the United States. This drug's been around for a while. Why hasn't somebody somewhere in the world done the sort of double-blind studies that would be fairly persuasive?
I don't know.
Gentleman from DeSoto.
Thank you, Mr. Chairman. Appreciate you being here. I had a question for Trevor, but you could probably answer this maybe even better. I don't know. But we talk about wanting to do clinical trials to see if this really has potential. But he just told us 1,500 Americans have come down there for treatment. I'm curious what kind of follow-up has been done with those 1,500 folks, and that should yield some kind of metrics that would be very helpful in making a decision whether we do clinical trials in the states or whether you lobby the FDA or whoever it is to try and get the schedule change. I just wanted to know about, do they check in on the people that have come down there and left to see what their metrics are, or what their reaction was? Was it long-term? Was it short-term? Did they still have integration issues, or was the recidivism back to drug use still high? Maybe nobody died, so we say it's 100% safe, but do we know if it's actually yielding the outcomes? And I'd like to know if they've actually done any follow-up with, there's your first clinical trial right there, the past people that have gone down there for the last 4 years, I think.
So Trevor's going to be able to answer those questions better than I am. But what I would say about study designs is when you're attempting to figure out what does what, you would want to put ibogaine up against a sham treatment or treatment as usual or another one of these psychedelic medicines in the same facility that you give them the ibogaine. And the reason, and then you'd have the same follow-up, and even the people giving the medicine wouldn't know what medicine they're giving. Right? So that's how you double blind a study, and then you can look at outcomes. And what you're attempting to do is to figure out whether the quality of care and the support services people are getting at Ambio, whether that has a bigger effect than the medicine itself. Does that make sense? So you
It
do
does.
have, yeah.
It does, but it seems like it's the same with like vaccine studies on children. You know, you have two different camps, those that would say that it has contributed to the increase in autism and spectral disorders, but nobody's going to do a double-blind study and not, against somebody's knowledge of what they're receiving. I think you can still draw a correlation as to whether or not there has been some significant recognizable impact to the individual that was treated, whether you hold it up against another drug or give them a placebo or whatever. So what I'm saying is that if there should be some studies being done on the 1,500 folks that have already gone down there. I'm sure there's other organizations doing this in Mexico and other places in the world, but I just think that would help us make a better decision because we actually have some real world metrics to look at and say, okay, this has potential promise.
I can feel the ants in the pants for the folks behind me. Is anybody here going to talk about long-term data? I'm getting a nod from the nurse on the dais. So I think we can
Yeah.
hear about long-term data.
I think we can address this with some of the other testimonies coming
Perfect.
up. So
Perfect. Okay.
thank you, Dr. Recor, as always. All right, next we have one of Mississippi's own veteran, Miles Grantham.
Good morning. It's an honor and privilege to be here. Chairman Creekmore, honorable members of the House and Senate Public Health and Service Committees and fellow Mississippians, my name is Miles Grantham. As I stand before you, a son of Mississippi and a veteran who found healing through an unconventional path, today I'm here to share my story and urge you to seize a transformative opportunity for our state and one that saves lives, cuts costs, and makes Mississippi a leader in addressing mental health and addiction. I was born in Greenwood, Mississippi to Howard Jr. and Kathy Grantham. My dad grew up in Lexington, my mom in Grenada, and my family's roots run deep in this state for generations. My grandfather, my father's side, Howard Grantham Sr., served as a medic in the Pacific during World War II, embodying the courage that shaped my path. On my mother's side, my grandfather, Cecil Lott, was a tree farmer in Carroll County, Mississippi. A man who worked the land with pride and grit, teaching me the value of perseverance. I was raised in Madison, where I graduated from Madison Central High School, class of 2001. While still in high school, I joined the Mississippi National Guard as a Cav Scout, driven by a desire to serve, kind of like my grandfather. And when September 11th happened, I felt a call to protect our homeland. I went to active duty in the Army, became Army Ranger, serving with 3rd Ranger Battalion. But in 2008, on my 5th deployment, I suffered an injury that cut my dream of a long-term career in special operations short. To heal physically, I had to join the U.S. Army shooting team, competing on the action team, that is. Despite my efforts, the injuries persisted. And in 2001, I was medically retired. I was kind of lost, wandering, contracting all over the world. It's kind of typical of guys that get out of special operations, start contracting. After a while, determined to build, I used my GI Bill benefits. I attended Columbia University in New York, did undergrad, grad school. But in 2018, while finishing grad school, I started to face kind of a new battle. I had started to have severe migraines and depression. This is something that never really experienced before. It kind of plagued me. And in April 2019, I found relief from that, and that was Ibogaine in Mexico. With the support of a veteran nonprofit, Veterans Exploring Treatment Solutions, and with founders Amber and Marcus Capone, I traveled to the Mission Within, a nonprofit clinic in Mexico for Ibogaine treatment. In a single session, my migraines vanished and my chronic depression was dramatically alleviated. For the first time in years, I felt a shift. This wasn't just a treatment, it was a lifeline. I've sent dozens of veterans to Mexico for Ibogaine treatment, and they've experienced the same successful results. One of those will be speaking after me is Mississippian Ben Bush, a former Ranger I've known for 30 years. He too found relief after leaving the Army. And for me, I believe in paying it forward, and us Mississippians have to stick together. And for me right now, Mississippi faces a crisis with opioids, and traditional treatments often fail, costing millions. The CDC estimates with each overdose, death costs about $11 million in healthcare and lost productivity. And Ibogaine, as I experienced in Mexico, offers a solution. It treats depression, addiction, past sexual trauma, and PTSD pretty much in one session, is what I found through my network of veterans I've sent down to Mexico. all my friends I've served with, they've all been down there for the most part. I would say about 95%. A Stanford study backed by vets and performed by Trevor Miller's Center Ambio showed about 93% of veterans reported reduced depression after taking Ibogaine. I feel that Mississippi can lead as Texas did with 50 million for Ibogaine trials in 2025. I believe no Mississippian should travel to Mexico for healing, as Ben and I did. This isn't just about cost savings, it's about self-sufficient quality of care for Mississippians. And by developing our own research and treatment programs, we'd reduce our reliance on the federal systems or out-of-state care. I believe we can create our own jobs, fund universities, build a model for the nation. Most importantly, we can save lives. Veterans like me and families struggling with addiction and communities desperate for hope. Ibogaine is a Schedule I, but with safety protocols, risk like heart complications can be managed. Chairman Creekmore, committee members, my journey from a Mississippi kid who ran creeks in Holmes County in the youth to cool off in the humidity to an Army Ranger to finding relief through Ibogaine shows what's possible. I say fund research, expand access, and make Mississippi a beacon of hope. Let's honor our veterans, strengthen our communities, and build a healthier, self-sufficient future for the hospitality state. And thank you for your, for this hearing.
Thank you, and thank you for your service, bringing honor to Mississippi and our country. Had you tried in your process to lead you to Ibogaine, had you tried other
Yes, sir. In
treatments?
2018 with the VA, other medications, all that stuff. And I was just kind of chasing something and nothing was working. And I had actually had some friends of mine from Yale they were at a gala with a doctor who's from Mexico. And this was back in 2018 when nobody heard about it. And they told me about it. And initially I was skeptical. I thought they were just going down to Mexico to do drugs. So I sent two of my buddies down to Mexico, veterans. One was Army Ranger. He was a sniper at Haditha Dam, and he graduated from Stanford Law. And another guy was a SEAL. They went down there, and they said it changed their lives completely and completely reset them. And for me, that was, and eventually I investigated, went down there and did it.
And of your circle of friends that you've sent to have this treatment, have any had adverse effects that you know of?
No adverse effects, but for me, it's not a silver bullet. It's a tool. I would say net positive, but you have to want it. You have to believe in it too, but that's everything. And for me, I'd say a 90% success rate with my network of veterans.
Questions? Gentleman from DeSoto.
Thank you for sharing your story with us. Is this something where if you come back and you start feeling a lot of that coming back, does anybody get treated twice? I mean, do they go back down again for another reset, or how does that work?
Yes, sir. I think it's up to the person. I do have friends. I've actually done it more than once, but it's a reset maybe every 2 years. For me, I had actual it helps out a lot of the guys and females with physical pain in the body, chronic pain in the body. Actually, I've had 4 shoulder, 2 back surgeries. And a couple of years ago, I did it again because my shoulder was really bad. And I thought I was going to have to see an orthopedic surgeon, because I already had 2 shoulder surgeries on this, and did Ibogaine and went in there and worked on my labrum and relieved that trauma to where there's no more issues.
Representative Porter.
Thank you. Thank you, Mr. Chair. I apologize for my tardiness. And so this question may have already been asked. What are some of the negative effects of Ibogaine?
Negative effects. I say the negative effects, if there's not a proper medical intake, there could be a cardiovascular issue. So there has to be a proper intake to see where they're at. If it's not done correctly, that's what I'd say would be the negative effects. You're not going to have anybody on the street corner doing Ibogaine, for sure. It's for a lot of people, they do it once because the reset isn't kind of intense for them. And they do it once and they get everything they need out of it, and they never do it again. But if you do have some people do it twice, they just need a reset. It was a couple years. Like for me, for example, I thought I was going to need another shoulder surgery. So I did it just to, went in there and fixed my shoulder.
Can you just briefly describe the process? Apparently it's not a very pleasant process.
It's about 24 to 48 hours, I'd say. The couple times I've done, I've been in it for about 30 hours, kind of like a dream state you're in. You're linked up to an EKG. You have, I know for Trevor and the nurse can speak more about this, but I know for the first 12 hours, usually a cardiologist right there. And you're going through a kind of like a visual, maybe a detox, physical, mentally. I know for people with sexual trauma, it kind of cleans that out too. Because I know a lot of people who have addiction issues, they've had sexual trauma in their background. So part of the coping is alcohol or drugs. So it goes and flushes that out, that childhood trauma out of their system. So that they may go through their body may start kind of moving a lot. And what is purging that trauma. So I know it's hard to say. It's like describing to somebody how peanut butter tastes, it's until you do it. And that's how I was when my friends went down. I asked them, well, what happened? And they just said, well, you just have to do it. And I was like, well, that's not information I can process. And until I actually did it, and it was just, for me, it was a life-changing experience. My migraines went away. Depression came in a week later, would move in, and then it moved out. And I never experienced it again, or migraines. And that was 6 years ago.
Thank you, Mr. Grantham, for your
Yes, sir.
time and especially for your service.
Thank you.
Next, we have another Mississippian and veteran, Mr. Ben Bush.
Good morning. Thank you for having us. My name's Ben Bush. I was born in Flowood, Mississippi. Grew up in Greenwood. My great-grandfather started farming in the 30s. It's a family operation. They still keep on today. Early childhood was pretty normal. I have a younger brother. We grew up hunting, fishing, playing all the sports. Very normal childhood. I got to see how hard my family worked. Mother was very loving and caring. So pretty normal Mississippi childhood. Well, my parents divorced in 1998. I was 10 years old. We were forced to move to Madison. I believe that's where my mom wanted to move. It was extremely hard. I remember, lawyers asking who you want to live with, and I just never gave them an answer. I didn't want to live with, either one without them together. So adjusting to a new town and new friends and new schools was rough. We went to Madison Ridgeland Academy. Finally, got into all the sports. That was kind of the escape. Thrived there. School wasn't really my thing, but graduated high school in 2005 from MRA, and decided to play junior college baseball. I played at Mississippi Delta Community College. Got to play with a lot of childhood friends. I knew the coaches close to home. I could hunt whenever I got off. Got out of practice, got out of class, and that was a good experience. After that, I went to Mississippi State. In 2008, I walked on Mississippi State's baseball team. Did not make it. I was pretty overwhelmed, immature, undisciplined, but it kind of put a chip on my shoulder. So I'm getting close to graduating college in 2010. Had no idea what I wanted to do with my life. Miles, his younger brother, we actually graduated high school together. He was finishing up pharmacy school at Ole Miss. So we decided to call him, tell him we wanted to join the military. And his brother Tyler ended up being colorblind. So I ended up going by myself. Well, Miles was kind of my mentor, got me set up with an option 40, which is a Ranger contract. And I went enlisted to basic training at Fort Benning. I showed up there at 23 years old. So when I arrived there, I'm getting a lot of questions about skipping out on the war, choosing college over war. Very, very toxic, but very, very interesting, eye-opening experience. Why are you not an officer? I wanted to do the enlisted. I wanted to do the cool things. I wanted to make it a short career. Well, 3 years led to 6. I ended up going to airborne school, RAS, which is the Ranger Assessment and Selection Program. And I got orders to go to Tacoma, Washington, which is 2nd Ranger Battalion. Well, all I wanted to do was be close to home. I went and knocked on instructors' doors. They told me, they asked what I wanted. I said, hey, is there any way I can get orders to 3rd Ranger Battalion? They're like, why would you want to stay here at Fort Benning, Georgia? Georgia's, the South's not good. And I said, I wanted to be close to home where I can go hunt and fish on the weekends. And they laughed and they said, yeah, we'll get you orders to stay at 3rd Ranger Battalion. So got to stay there, graduated there, reported to my platoon, did a training cycle with my platoon, learned my job, learned it well, and we deployed. It was a winter deployment, not much going on, got to learn a lot, got to walk a lot in Afghanistan, and come home, and I did pretty well in that deployment, went to Ranger School, graduated Ranger School in 2012, and deployed again right after that. That deployment, we was a little more combat, it's a little warmer weather, and we ended up losing 2 Rangers to an IED, and it was called Operation Aries. It's one of the biggest mass kills since Vietnam, and that was kind of eye-opening experience since we had to regroup and continue to work on that deployment and go out on target. So come home, ended up meeting my wife in 2014. She's from here. Met her on home on leave. We dated for a year. We had a long distance relationship. I'm at Fort Benning. She's here. Kept it together, went home on the weekends, and I ended up getting a sniper slot to go over to sniper section at 3rd Ranger Battalion. So go to sniper school in 2015. My wife and I got married short after that. And we had to break it to her that we were deploying in 2016. And this deployment, our deployments are usually around 60 to 90 days. This was kind of during the ISIS takeover, and our deployment got extended a few more months. So it turned into about 120-day deployment. We had a few guys get hurt. It was very rough, very physically demanding. And I shot over 100 rounds of 300 Win Mag in one day. That was the last mission that I ever went on. And I'm coming home. We're coming home. Everything was okay. And I ended up tearing a lot of ligaments in my ankle that deployment and fell down a 20-foot ravine, kind of hurt my back, and go through the VA process, the Army doctor process. And I'm like, hey, I'm ETS and I'm getting out of the military in November. This was around September timeframe. And I'm like, I need to have surgery on my ankle. And they go, oh, well, we'll schedule you. We got you an x-ray scheduled for December. And I'm like, okay, that doesn't make any sense. I need, I'm ETSing in November. I'm ready to get out. I was just kind of fed up with the process. I'm hurt. And so I come home. Our first child was actually born in November. I had ankle surgery here in Jackson. I went around military doctors, came home on leave and paternity leave, got my surgery done, and reported back early November to Fort Benning. And I got to see kind of what it's like going around your chain of command and taking care of yourself, going through the proper levels. And they decided to keep me there until February to do rehab and would not release me until I was 100%. So my wife's at home with a newborn child working, full-time job, and I'm stuck there doing rehab. And I ended up getting back to 100%. I ended up ETS and getting out of the military in February of 2017. So I thought the transition was going to be easy. Got a college degree from Mississippi State, special operations experience, and I applied for over 100 jobs and heard the same thing. You know, you're not experienced. You have no background. You know, I'm kind of the only thing I'm good at is military stuff. Well, applied for a few law enforcement jobs, didn't get those, didn't know why. Life's crumbling. Depression kicks in, anxiety kicks in. Going through the VA process, I get a primary care provider locally as my primary care doctor. Went in his office, kind of told him what was going on, maybe talked to him for 10 minutes, and he prescribed me 2 different antidepressants. So, you know, wife's aware if something's not right. You know, I'm kind of like, whatever, this is normal. So that medication made things severely worse. I battled that for around 3 years. I had 4 or 5 jobs. I would work a job for 3 months, quit, didn't like it. Money wasn't good enough. Wife's a nurse, so kind of kept us afloat. Our second boy was born in 2020. And about that same time, I got a phone call that there's a contracting job, a GRS job with the CIA that's looking for special operations guys to come do security over in Iraq. And it's probably the greatest single guy's job you could ever have, especially as a special operations veteran. And my wife was fed up with my battles, what I was doing. I was hard to be around. A lot of anger. No sleep. I'm running myself to death up and down the road just to get tired enough to fall asleep at night. And a lot of physical pain, and I'm tough. I can get through this. I can battle it. Well, end up going to DC, ended up doing a lot of training over in West Virginia. I get the job and I deploy for 60 days and come home. And you can schedule your deployments as a contractor however you see fit, but in order to make good enough money to support a family, you need to do probably 3 or 4 trips a year. So first year I'm gone overseas 6 to 8 months a year, and my wife's working full time, and I'm actually running away from problems at home. And Miles and I kind of stayed close, and he mentioned Ibogaine in Mexico. And I'm like, well, how much is it? I want to say through that program with flights and all, it was around $5,500. Well, he found a sponsor, a CEO of a company that mailed me a check to pay my way to go down there. And that process was, I was nervous about it. It's out of my comfort zone. Didn't know much about psychedelics except whatever you see in hippie movies, but they coach you up. They sent me a pamphlet with all the information. I studied for a week, and they tried to explain to me that I needed to be clear-minded, stress-free when I arrived. Well, the ice storm hits Jackson in February of 21, I think it was. That was the week that I was supposed to go. And my poor wife's like, you can't leave and go to Mexico with the power goes out. So I'm trying to talk my way out of this trip. And fortunately, the airport shut down the day before I was supposed to fly out. So had a week of redoing that over again, getting coached up, researching. They're prepping me to go and fly to San Diego. Keep in mind, this is in between contract and deployments. So I'm home for 2 or 3 months. And I'm like, surely this is, not going to affect my job. I'm not going to tell anybody about it. This is important. So I had a lot of information, someone that I trusted that helped me get through this. And Show up to San Diego. I meet the doctors, the nurses, the program manager, and I'm with 3 other SEAL team guys. And we drive down to Tijuana, Mexico. We rented a house, or they had a house rented, and it was very professionally ran. We did blood work, EKG machine, got all that stuff done, and went through the process. And I did not really know what to expect, even though I've done a lot of research and had, I just couldn't believe what they were saying. And my experience was pretty brutal in the fact that I had a lot of physical pain in my feet and my back. So I was trying to talk to the medicine and trying to control it myself, fully aware of what's going on. But I kept having the same 4 visions, the same 4 dreams. It was my brother and I playing as childhood buddies, and I saw a dead body, and I saw an alligator's hide. I don't know why, but I kept seeing it over and over and over, and I got tired of seeing the same thing. I don't know what that means. And it hit me that I was going to throw up. And I knew I had a bowl next to my bed. Well, I could not feel it. And I was like, I'm sorry, I'm about to just throw up on the floor. So I roll over, throw up, and lay back down. I do it again. And I realize I'm trying to see, like, there's no throw up on the floor. So I pull my sleep mask up, and there's a nurse holding a bowl for me the whole time. And I don't know if she knew, I'm laying next to 4 other combat vets. I don't know if she knew it was coming or what, but that medicine, it humbled me and it beat me down to where I gave my life to Christ that night. I gave up. Take me. I don't care, what happens. I'm at peace. And it finally, I remember maybe 6, 7 hours later, it kind of calmed down, and I slept all day the next day. I woke up and I left Mexico feeling like I weighed 100 pounds. I probably did not say more than 10 words for about 2 days. Very calm, very collected. Got home, wrote a lot of notes down about my experience. Obviously told my wife, and her being a nurse, she still didn't even understand, what I'm talking about. But I dipped tobacco for 8 years, stopped that day. I had no desire for alcohol. I maybe drink a couple beers once a month, but don't enjoy it. And I developed new habits. I used to be an extremely routine guy. If my routine got messed up, I was pretty angry. And I was in a dark place. I decided that before that, I skipped that step. Obviously, that's a pretty important step, but I decided to take my life at Dollar General on Highway 51 one day. In between deployments. And my wife and I weren't doing good, but I said, if she does not answer the phone, I'm going to do it, because I'm going to open up to her and kind of tell her what's going on. And she didn't answer. So I picked up my pistol in my truck, and she called me back. And I explained everything that's going on. I'm not as tough as I think I am. Done a lot of stuff that requires being a man, but I just can't do this alone. And fast forward, after my Mexico trip, I just took on life head on like a grown up, and had a clear path, clear mind. Nutrition, fitness were very important. My body, or my physical pain, slowly went away. Got closer to God. I don't need routines anymore. I can adapt on the fly. Don't get angry. I have a sales job now, which I love. I put people first, but I've always put people first. But at the time when I was struggling, I never self-meditated or self-medicated myself. I didn't take care of myself first, but now I kind of can take a step back. Things can wait now. Make sure I'm right now before I move on to take care of other people. But it literally changed my life. If it didn't heal me right away, it bought me time to where things could get better. And it just gave me a new chapter, this is what life's supposed to be like now. And then when Representative Creekmore and Miles and them kind of came to me, kind of share my story, I was like, absolutely. I've been asked today if I ever got any negative backlash, and I haven't. I spent a lot of time with a big supportive crowd. The only one that's really given me backlash is my wife. Like, why are you telling people about this? Why are you sharing this with people? And I'm like, I'm telling everybody about this if I can, if the situation comes up. And I had one more trip, being home for those few minutes, I had one more trip to Iraq as a contractor. And I told them it was going to be my last trip. I'm going to find a new career. This is not fair to my wife and my family that I'm gone. My wife calls me and says, I'll get I've got a new job. I'll make enough money till you figure out what's going on. So when I get back, I have a meeting at base, and anyway, kind of clears out. Well, there's two former Ranger guys that I was close to working over there, and I tell them about this journey I went on in Mexico. And they were struggling with home life, and one was going through a divorce, and the other one was on the verge of divorce and a lot of alcohol. So, they call me when they get home. I link them up with Miles. We linked them up with Mission Within, and they went down there and went through their process. And I told them to call me back, whenever they get home. And they didn't call me back when they got home. It was about a month or two after. They both called me in the same week and told me, you saved my life. And the other one told me that I saved his marriage. So last week, I had to go to Raleigh, North Carolina for a work trip. Well, on my way back, I had been texting Miles and Representative Creekmore about this week, and it clicked. I called one of those guys, former Ranger buddies, and I said, hey, this is what we're trying to do in Mississippi. Can you in detail give me kind of an idea of how it saved your marriage? And he tells me during his process, during his journey, that he saw his wife. They had been trying to get pregnant for 2.5 years. He saw his wife in his dream, and she was wearing a blue dress, and turned around to look at him, and she was pregnant. And he's like, man, I just kept thinking about that. When I went home, I kept thinking about that. I told my wife about it. And a month later, she was pregnant with a boy. So take what you want with that information, but I think there's a healing power, and very fortunate to be an advocate and supporter and spread this message to fellow veterans and other people that need help. So thank you.
Thank you, Mr. Bush. And thank you for sharing that story. And please thank your wife on behalf of the Mississippi Legislature for that. Do we have any questions for Mr. Bush? Thank you, sir, again for your service and for your testimony. Next, I have another Mississippian, Ms. Claire Durst.
Good morning, Chair, members of the committee. Thank you for the opportunity to speak today. Thank you for listening. I'm happy to answer your question after. Just remind me. You'll never be the same. No, you can't. No, you won't. No, you don't. That was what I heard over and over and over again after I suffered a traumatic brain injury while beginning my military career. I was a trauma nurse with over a decade of emergency experience, trained to save others. Suddenly, I couldn't save myself. I spent 6 years disabled, no longer working, no longer myself. I followed every protocol, I took every pill, I did every therapy, every procedure. For 6 years, I took Ambien, a sleeping pill, and Klonopin, a tranquilizer, under medical supervision just to function. But improvement never came. And 3 months into my treatment plan, my doctors, right here in Jackson, they quit. They stopped trying. The system I dedicated my life to didn't believe in my recovery. And that left me with the brutal question, how could I save other people for 10 years and nobody could save me? So I searched. I sought out treatment across multiple states and even in 2 different countries. Still struggling, I finally found a tool that changed everything. Ibogaine. My name is Claire Durst, and I'm a 5th generation proud Mississippian and a graduate of the University of Mississippi Medical Center, where I earned my bachelor's and I was inducted into the School of Nursing Hall of Fame. I've spent 18 long years on the front lines of trauma, from small town, rural Mississippi ERs to the back of ambulances on back roads to the busiest, most bustling hospitals in the United States, and leading medical operations at an Ibogaine clinic in Mexico. I'm also proud to be a board member of Operation Path Forward, a veteran nonprofit helping with these efforts to save our guys. I come from a long line of military service. I've seen war, I've seen suicide, I've seen addiction consume not only some of the strongest men and women this country has ever produced, but my own blood. I've seen what happens when the system we trust has no answers. Before I received Ibogaine, I had the privilege of witnessing it. As a nurse, I was as skeptical as you are looking at me right now. Healing trauma through a ceremony with visions and dreams sounded like a scam or wishful thinking at best. There was nothing you could have said to me to convince me, absolutely nothing. But then I started to watch. I sat up through the night alongside some of the bravest and baddest soldiers our country has produced, and their spouses and their children, heroes. Ceremony after ceremony, treatment after treatment, I held hands, I wiped tears. I sat in silence. I watched people shed years of guilt, shame, grief, like a weight being lifted off their chest right before my very eyes. And they even looked different. The deadness in their eyes was gone, replaced with the light of life, hope. With each beep of the monitor, a reset. Many of these veterans are still in my life today, more often than friends or even family, because we are a new kind of family. They share their growth, their wins, their challenges. But the difference now is they have tools. Setbacks aren't breakdowns anymore. They don't reach for the bottle, for pills, or a trigger. They move through it. And I watched this over and over. So I took the dive. My TBI symptoms were crippling. Migraines, dizziness, ears ringing, blurred vision, over-medicated, and miserable. I needed to be free, and that felt impossible until I woke up from my own treatment, on my mat, soaked in tears. I knew I would never be the same. Ibogaine didn't just detox my body. It gave me access to something that Western medicine never could, the subconscious roots of my trauma. And that's what I want you to understand today. This isn't just emotional, it's neurobiological. and it works where traditional therapy can't. So let me explain. Think of the brain like a house. Traditional therapy is like standing outside shouting through the window. You can clean the living room, you can open some doors, but the trauma, the root of addiction, is locked in the back room. That locked room is your subconscious. And meanwhile, the house is on fire. So ibogaine is the key. It's the key that opens that room, lets you walk in, see the source of the fire, and put it out. Ibogaine resets the default mode network, which you previously heard today, interrupts compulsive behavior loops, and opens a period of neuroplasticity, the brain's ability to rewire. It's not just psychedelic dreaming, it's the rewiring of trauma circuits under conditions where healing becomes possible. And importantly, ibogaine is not addictive. You ask anyone who's gone through there, do you want to do it again? And almost all will say no. It's not euphoric. It's not recreational. It's the hardest psychological work a person may ever do, but the results speak for themselves. Yesterday, you might have heard at the Kentucky ibogaine hearing, a young lady testified, former addict. She revealed in her ibogaine experience, she saw her own funeral, her body in a casket, saw her mother sobbing. And ibogaine allowed her to access and experience all the pain that she was causing. And she felt it. That's the moment of awareness that shattered her addiction. That's not just therapy, that's transformation. So when I hear someone ask, why can't this happen in a traditional rehab setting without ibogaine? It's just a dream, right? Well, the answer is very simple, because for many addicts, it's not about the drug itself, but it's the pain that it's masking. The pain that lives in the subconscious, often buried under years of trauma, years of shame, and emotional isolation. And because in rehab, the conscious mind is still defending the trauma. With ibogaine, it's able to temporarily disarm those defenses, doesn't create an escape from reality. It provides access to it and allows a person to confront it head on with clarity and presence in a safe space. This is not sedation. It's not numbing. It's facing the truth. That's why the healing sticks. The person isn't high. They're awake, but inside their own story, finally seeing the root of their suffering. We cannot heal what we cannot see. And ibogaine allows people to see their wounds and then heal it. Since my own recovery, I've helped hundreds of veterans access this medicine. I've seen suicidal ideation stop. I've seen panic attacks stop. I've seen people detox without withdrawal and stay off opioids. They were finally free. But every day we wait, we lose more lives to suicide, overdose, and despair. And I don't say that lightly. I've lost people I love. I've worked ERs so overwhelmed, so overcrowded with suicidal patients and overdose cases. Feels like all you do is pronounce time of death. We're seeing record highs. Our systems are bursting at the seams. These are not just numbers. These are people that should still be here. I get phone calls daily. Veterans, spouses, mothers, sons, begging, please help me make the nightmare stop. Can you please stop my pain? Help me, help me, help me. Wives terrified their husbands aren't going to survive another week. He can't hang on any longer. How much longer? How much longer? Or staying on the phone, talking somebody down with a gun in their mouth. That one's pretty regular. My own brother, a Marine veteran, lost 3 platoon brothers in 3 weeks. First it was Will, then it was Corey, then Chucky. I was sick the whole next week waiting on him to call me again. This is the first time I'd not slept since ibogaine. Do you know the scariest part to all of this are the calls that we don't get? Most people suffer in silence and they die in silence. They never make the call. And I lie awake at night thinking, where do I send them? What can I offer that actually works? That alone makes me want another sleeping pill. We need better tools, better options. We need clinical trials, and we need them now. In the U.S., ibogaine remains illegal, forcing desperate Americans to cross borders if they can afford it. We need to make this accessible, affordable, and safe. We have the medical knowledge to do this responsibly. Let me tell you how. First, you ensure that a patient is mentally prepared and medically appropriate. We perform medical and psychiatric screenings for clearance. Not everyone needs ibogaine. It is not the answer for all. There are other options that we have. Next, we do a full cardiac screening with testing. We do EKGs, echocardiograms, lab work. We identify any pre-existing heart conditions. We know that this medicine causes prolonged QT intervals, and electrolyte imbalances are important, but we can fix all of these issues. We can avoid any of these problems. We provide continuous heart monitoring throughout the treatment with clinical oversight, doctors, nurses, 24/7 at your bedside with monitoring. The same care that we offer for high-risk medications and anesthesia in the hospital now. And lastly, most importantly, we offer structured aftercare and integration support, because healing doesn't end with the treatment, and healing doesn't happen in isolation. Community, it's the biggest part of the veteran program, is the community that they make when they come out of these treatment programs, because they have a new life to live. Continues with therapy, peer support, reintegration. These are the keys to long-term success. And these are not theoretical protocols. They're standard clinical safety measures, things we already do every day in the hospital. We just need to apply them to this medicine. Because yes, there are risks, most notably the cardiac risk, but we can mitigate those risks just like we do in everyday medicine. We give chemo with risk. We perform surgery with risk. We can do the same with ibogaine. If we just invest in research today, we may one day even isolate and remove the cardiac risk altogether. But we will never get there if we're not allowed to study it. Clinical trials are the first step, not the final answer. And the promise is bigger than PTSD or addiction alone, as ibogaine is showing early promise in conditions with overlapping neurological conditions like Alzheimer's, Parkinson's, multiple sclerosis, autoimmune diseases, treatment-resistant depression. Because the truth is, these symptoms rarely exist in isolation. A veteran with TBI almost always has PTSD. PTSD almost always includes depression and suicidality in all of them. All three. Ibogaine doesn't treat the symptoms. It heals the root. Meanwhile, veterans are dying every day, 22 reported to suicide. And that number is not going down anytime soon. Veteran organizations are at their limit trying to send people overseas just to keep them alive, and we need to stop that. We need to keep them safe. We need to keep them here on home soil in our care. We are responsible because we sent them to war, and now we fix them. I believe Mississippi, where I trained, has the grit and the willpower to lead. We've always done more with less, and we've done it well. I didn't come here today just as a nurse or just as a provider. I came here as someone who has lived this. Ibogaine didn't cure me, but it gave me my life back. And it has the power to do the same for thousands of others. We don't need another decade of suffering to prove what we already know. We're ready to lead, we are ready to study, and we are ready to heal. Thank you.
Thank you, Ms. Durst, for that powerful testimony, and thank you for caring about your state of Mississippi. Do we have any questions for Ms. Durst? Gentleman from DeSoto.
Thank you, Mr. Chairman. Thank you for being here and sharing your testimony with us. I'm curious about the facilitation of it. Is it given in treatment intravenously or by ingestion? And then also who is your supplier? I mean, where is it synthetic, or do you get it from West Africa? Or so could you speak to those two things as delivery and also sourcing?
So
Okay.
as far as administration goes, it's given in a capsule. It's ground up. We weigh it out based on a calculation, a weight-based dose, but we also take into effect how I spoke to the lab testing and medical health screening. We take into account all different factors. It's very individualized dosing. Not everybody gets the same. That way it's customized for you. So it's ground up, placed in a capsule, weighed out, and it's just swallowed orally by mouth. The acquiring of it, yes, there's compacts with tribes and organizations in Africa that have they have partnered together with iboga plantations where it's grown. So there are great relationships between the two. And I'm sure Trevor might want to speak more to that since he's part of that. His partner is part of that as well. But does that answer your question for now? In regards to the long term, I just want to quote something off of here. So my mentor in this space is a doctor. His name is Bruno Rasmussen. He's in Brazil. He's been my mentor since I started. He's been providing Ibogaine in Brazil for 31 years. And I did reach out to him about their treatments over there in the follow-up. So they have studies, long-term studies, up to 20 years, abstinence from crack and cocaine. They do have other data, and he shared some numbers with me also. 62% after Ibogaine and psychotherapy alone, 72% after Ibogaine, psychotherapy, and other medicine like antidepressants or mood stabilizers. And he was the one on the forefront to bring it to Brazil. And they're actually looking at possibly getting it into pharmacies, low doses. He's a great resource. I'd be happy to share the studies and talk to you about him after this.
Thank you, Ms. Durst. We are going to power on through this. I know if anybody needs to take a break, just feel free to get up, but would also like to call up our next witness, Mr. Jeffrey Lawrence.
Thank you, Mr. Chair. Members of the committee, my name is Jeffrey Lawrence. I am the research director at the Reason Foundation. The Reason Foundation is a libertarian nonprofit think tank. It's been around for 50 plus years. We're a national group. We work across the states across a number of issue areas, ranging from it's a little about us, ranging from pension modeling and solvency to transportation finance, education. But over the last 10 years, especially drug policy is an issue area that has been a big focus of ours. I think here in Mississippi, you've probably seen our actuarial team talking about pension solvency in the last couple of months. But today, of course, we're talking about Ibogaine. And I'm going to skip around a little bit in this presentation in the interest of time, and I don't want to be repetitive of things that you've heard, but additive. I also apologize for all the words. It's load the slides up with words mainly for the benefit of the record. Let me skip to here. So I think one of the unique things about Ibogaine is that it is one of the very few things on earth that is a neurogenerative compound. That is, it creates new brain cells, repairs brain cells, because it kind of prompts the expression of these two proteins listed up top here, GDNF and BDNF. These are proteins that lead to neurogeneration, and what that means is that Ibogaine has a lot of promise for a range of diseases, neurodegenerative diseases, traumatic brain injury, anything that causes kind of physical damage to the brain and then has physical manifestations throughout the body as a result. And so, I think you heard about the Stanford study here that was done at Ambio with the 30 veterans. The follow-up with those, these are all small sample studies to this point, but the follow-up with those veterans showed massive reductions in PTSD symptoms, 80%, 87% reduction in depression symptoms. So, the behavioral changes that go along with an improvement in brain structure and brain function are pretty clear and have so far have had a lasting impact. So I think one of the big things of interest with ibogaine has been its potential ability to treat opioid use disorder, because as with traumatic brain injury, where you have a soldier who has repeated concussive blasts that compromises the structure of their brain tissue, opioid use disorder is also a form of brain damage. It causes the amygdala to shrink, which is associated with kind of mood control and emotional state. It also impedes the formation of key neurotransmitters, impedes serotonin uptake, and that has a lot of effects on the opioid addicted person's mood and behavior, as well as their ability to kind of modulate day-to-day body functions, right? And so when you have an opioid addicted person who tries to quit cold turkey, they go through massive physical withdrawal symptoms. And those can actually be fatal if this is a heavily addicted person. So ibogaine, through its physical modulation of the brain, can mitigate those physical symptoms. And at the same time, it creates this very introspective period that you've heard is a psychedelic experience that can last 24 to 48 hours and induces that person to really question their life decisions up until that point. So it has both a physical and a psychiatric effect that can be beneficial for opioid addicted people. And in very small sample sizes, it has shown about a 75 to 80% success rate in helping people overcome opioid addiction and remaining abstinent for up to a year. So that's a huge success rate. The existing 3 FDA-approved treatments for opioid use disorder are Suboxone, methadone, and buprenorphine. All of them have success rates of about a third of that level, 18 to 25%. So in terms of the effectiveness of treating this disorder, nothing compares to the promise that ibogaine might have. Now, I say might have because these are small sample sizes. There have not been large-scale systematic clinical studies to date. You also heard from Mr. Miller that ibogaine has shown some real promise with neurodegenerative diseases like MS. And he talked about the shrinking of the brain lesion in an MS patient. So that's a great thing to hear, but I always think seeing is believing. So here's a brain scan actually of an MS patient with a large brain lesion that you can see. The images on the top are taken at 1 month post ibogaine treatment, and you can see on the left hemisphere there's a very large black circle, which is a brain lesion. It's clearly visible in all 3 of the top photos. And then the photos on the bottom are taken at 3 months post-treatment. And you can see that lesion has shrunk quite noticeably. So this is the neurodegenerative property of ibogaine. This is an MS patient, but of course, this is what happens to all different types of brain disorders with ibogaine. So I mentioned that buprenorphine and existing opioid use disorder treatments have very limited effectiveness. There have been a number of studies examining this effectiveness. Here's kind of a chart of some of the more recent ones looking at buprenorphine. The success rates are in of achieving long-term abstinence are in the far right column. And all of these studies have kind of different parameters. They treat people for with different dosage rates or for a different period of time, and they wean them off over shorter or lesser time spans. But you can see that most studies are showing success rates between 17 and 25% with buprenorphine. And you need to take buprenorphine or methadone or Suboxone for a very prolonged time period because instead of kind of repairing the brain, you're essentially weaning the brain off of its opioid dependency. And so these medications need to be taken daily and sometimes over the course of 18 to 24 months before a person can fully heal and be able to operate independently of any opioids. That's part of the reason they have low success rates, because a person who's in recovery very often does not have a car, cannot get to a methadone clinic on a daily basis. It's a huge time commitment. It makes it difficult to get a job and live a regular life if you're kind of committed to this schedule. And that of course contributes to very low success rates. I'm going to skip ahead here. So this also has significant fiscal impacts for states, because most opioid use disorder treatment is financed through public insurance programs like Medicaid. If you have a patient who is going through this treatment through a buprenorphine regimen, for instance, that person is likely to be, if they're going to be successful, it's going to take about 18 months. But most people who try to go through recovery go through it multiple times. They're not successful the first time. And so a typical patient will initiate treatment between 2 and 5 times, right? They're going to go through an initial 30 to 90-day program, and then for about a year and a half, they're going to be on this daily regimen. The cost of covering that is about, you can see up here, about $130,000 per attempt. So if you're going 2 to 5 times, you're easily talking about $500,000 being spent in public dollars trying to help this person overcome opioid addiction. What's the comparative cost effectiveness with Ibogaine? Well, potentially, Ibogaine is 3 times as effective. It's effective after a single treatment, some cases twice, but huge success rates after a single treatment. And even if you blow the costs out of the water, you put someone up in a 5-star resort, they fly first class to get treatment, and then they have 6 months or a year of counseling afterwards. The max that we can even calculate being spent on a treatment is about $60,000. So by comparison, about 1/10 of what can be spent on a methadone or buprenorphine course of treatment. Of course, you heard Mr. Miller say that the cost of receiving Ibogaine treatment in his clinic is about $8,000. So this amount is really inflated. So we think that Ibogaine could be a hugely cost-effective, beneficial program for states to have in their kind of quiver of weapons to deal with opioid use disorder, and lead to both greater healing and fiscal savings. So let me get to brass tacks. What are we ultimately going to hope that the Mississippi legislature will consider is that Mississippi could participate alongside other states in a coordinated clinical trial pursuing FDA clearance to use Ibogaine as an approved pharmaceutical product. Now, I know there's some discussion earlier about a Schedule I substance. It is legal to put a Schedule I substance into trials that are supervised by the FDA. It's just a little more difficult. You have to adhere, the drug sponsor must adhere to some additional DEA protocols for security of inventory, but there are a number of Schedule III approved pharmaceuticals now that are derived from Schedule I drugs. Dronabinol, for instance, is a pure THC compound. That's the active ingredient in marijuana. It is an approved pharmaceutical, has been since the 1980s. Epidiolex also is an approved pharmaceutical. It's approved in 2017. It's an extract from marijuana. And so it is possible to do that. So far, there are 3 states that have done something to commit funds toward clinical trials, hoping to collaborate in one big multi-state project together. So you've heard that Texas has allocated $50 million toward clinical trials. Arizona also has allocated $10 million. Both of those are on a dollar for dollar match with a private partner. So there's an opportunity to leverage public funds and a public-private partnership. Ohio has also created a fund for this purpose, although they haven't appropriated money into it yet. Now, in the case of both Texas and Arizona, they appropriated general fund dollars. We believe that you also have the option of committing opioid settlement funds for this purpose. Now, those are restricted funds intended to mitigate the impacts of opioid addiction. We think developing a novel approach for doing that fits within the the restricted parameters of the settlement. So that would be a way of going about this that does not impinge upon your general fund obligations. Let's see if I can. So I think one of the things that states will need to consider as they go about this is that when a drug sponsor petitions the FDA for an investigational new drug process, the FDA then has to approve the study design, and that study design must be coordinated and replicated with geographic diversity. So it's actually a benefit to have multiple states partnering in the same group and allocating money for trials that could occur within their own state, because that kind of benefits the study design itself. But states will need to collaborate with one or more drug sponsors. So that means that the states will need to partner together and decide who those sponsors will be, and allow the sponsor to be the petitioner for the investigational new drug application. And the states, what we do not want to see is the states appropriating money and then going off kind of independently conducting their own research trials, because that would not contribute toward an actual FDA approval. It needs to be on a coordinated basis. And so one of the things Reason Foundation has done is we've prepared model legislation for states that are considering this, so that they can kind of easily bolt on their efforts alongside the first mover in this, which is Texas, so that all the states can move together. They can collaborate, decide which sponsors they're going to work with, and work as one big team, hopefully toward the big goal of ending the opioid crisis in America. So with that, I'm happy to take any questions.
Ms. Scott, did that answer your question on how the collaboration will work?
In this, Texas is doing 50 million and they're creating these clinical trials.
Ms. Scott, will you speak in the microphone so our online listeners can?
Arizona in this so-called Manhattan Project. Now, what is their responsibility?
So Arizona has appropriated funds that are conditioned on receipt of matching private funds, which have already been committed. So there's going to be $20 million going into a pool. It's going to be currently it's kind of at the discretion of I think it's the HHS director as to how they're going to channel that. Although there's some direction in the statute that kind of points toward a research center that's existing in Arizona. But certainly they have to. If they're going to work with Texas, they have to be able to coordinate with a single drug sponsor.
Yeah, I guess that's what I'm trying to find out, how the consortium would actually work. So each of these states will be doing some type of research, is what you're saying?
Yes. So our vision is that we have a consortium of states that, every state maybe sends a delegate to a governing body, and that body decides which sponsors all the states are going to work with. And the sponsor then has to design the test parameters and get them approved by the FDA. But the states themselves can then appropriate, they would have presumably already appropriated money into a fund. Then they would disperse money from that fund to a facility in their own state that is equipped to meet the study parameters.
Okay, and then I guess my last question, you discussed a very small sampling as it related to opioid use and for Mississippi, what they've been telling us is what this will do for opioid treatment. In this Manhattan Project Consortium, we know that you have some information on what it has done for veterans, people with PTSD, TBI, and all that. How does that fit in the development of the study and going forward for the opioid addicted person? How is that
Yeah.
going to fit in that?
So there's a couple ways to answer that. First, if the states decide that they want to appropriate money for the treatment of the use of Ibogaine to treat a number of conditions, the states in collaboration could launch a number of parallel trials as treatments for different conditions. A different way to go about that would be to put kind of all the eggs in the opioid use disorder basket, hoping to get FDA approval. And then once the FDA has approved a drug, it can be prescribed for off-label use by a physician.
And so that's really what you're recommending. That would be where you're not recommending anything.
Not necessarily.
But that probably, to get a significant number of states, that probably would be the better way to do it, because you could sell it that we're going to be helping PTSD, TBI, but MS, opioid, I mean, the whole thing, right?
Yeah, well, I think clearly Ibogaine has a use case for all of those conditions. I wouldn't presume to speak for the collaboration of
Well, we
a
don't
dozen or more states.
We just talking here.
Right. Yeah, I think both of those pathways are probably reasonable. I saw that Brian may know, I think there are about 7 pharmaceutical companies that have initiated some level of trials already, looking at different use cases. And so it could be that the consortium of states decides they want to partner with multiple horses and kind of see who gets to the finish line first. That would be one way to go about it.
Senator Bryan?
As I understand it, the suggestion is that the states or a group of states help fund the cost of the procedures necessary to get FDA approval.
There are different ways that companies design their trials. So some pharmaceutical companies totally capitalize the costs of the trials up front. Others have sold access or the ability to participate to the participants. So yeah, that is one way to go about it. But I think in this case, the public use or the clear public interest here in treating opioid use disorder and potentially lowering the state spending through Medicaid on treatment of these diseases justifies the use of some state resources here, particularly, especially if those resources are already restricted for treating opioid use disorder.
Again, the proposal, as I understand it, is that a group of states would help pay for the trials necessary to get FDA approval. Is that right?
Yes.
Well, the world is full of drug companies and the world is full of venture capital. Why wouldn't some drug company or some venture capitalist be funding this without the states doing anything?
Okay, that's a great question. It relates to another question I heard earlier, actually. Why haven't large-scale studies on this been done before? The reason is because of, I believe, because of the economic incentives facing drug companies. Because this compound is a naturally occurring alkaloid from a plant that has existed for thousands of years. That means that it's not novel. Being not novel means it's not patentable. And without a patent, the drug companies just don't have the incentive to pursue a pure version of Ibogaine, at least, on their own basis. So it would need to be on a public interest basis. Now, it could be that a modified or synthetic version of Ibogaine if it meets the novelty threshold, could be patentable, in which case it generates an IP interest that a pharmaceutical company might want to pursue. However, under this kind of Manhattan Project proposal, what we do view it that way, that a company will probably develop a novel version of Ibogaine. But the states being kind of capital partners because they have a public interest in this, would then also have an ownership interest in the final intellectual property that comes out of an FDA approval. So they would be partners that receive distributions to the extent that that technology is profitable.
Well, it seems that simultaneously you're saying that it's not financially rewarding for drug companies because of the inability to get a patent at the end of the day. But at the same time, the states are going to get a royalty stream from the drug.
So that would only be in the case that the drug under examination is a modified or synthetic version of Ibogaine that meets the novelty threshold. So it would not be kind of botanical natural Ibogaine extract.
The first line on your slide says that 3 Republican states have done this without trying to define exactly what a Republican state is. Is there anything about the drug that's more effective on members of one political party than another?
Definitely not. Actually, I didn't realize that was in there, but it's so these are states where the legislatures are Republican, led by Republicans, of course. We find, as a libertarian group, we often find that surprising that Republicans are leading on a drug policy issue, and so I guess that's noteworthy for us.
Gentleman from Lee.
Thank you. I want to know, when you look at the Manhattan Project, what type of procedures do you have in place for individuals who want to get into this type of study? What guidelines do you have in place since you have already started one? So do you have any guidelines in place to pick out an individual that want to get into this type of procedure?
I can't speak to that because that would be dependent on the research design that's selected by the drug sponsor.
Okay, thank you.
Thank you, Mr. Lawrence. Appreciate your presentation. All right, next we have Cipriana and TK Kwan sisters. Welcome to Mississippi.
Before we start, does anyone have the time by any chance? The time? Okay, that was just me determining to say whether good morning or good afternoon. So good afternoon, everyone. I also just want to say that we are twins and I know everyone's allotted 15 minutes. So ours is 13 minutes each. So a total of 26 minutes. So we are 2 people. So I just wanted to let everyone know. Okay. Good afternoon. First, I would like to say thank you to each and every one of you for taking the time and having the compassion to being open and listening to our stories. My name is Cipriana Kwan. Good afternoon. My name is TK Kwan. We're identical twins, writers, speakers, public health and wellness advocates, ambassadors for Americans for Ibogaine, and we're childhood abuse survivors. No matter what you look like, what your religion is, what your political position is, we all feel pain. And many times how we process the pain is through coping mechanisms that may serve us in the moment, but are not beneficial or sustainable over time. Our grandfather and both our uncles are veterans. And even though we may not be veterans, we know what it's like to be at war, to survive a life-threatening conflict, not once or twice or more than a few times, but every day of your life for over a decade. In the words of retired Navy SEALs Marcus Luttrell, quote, "A tragic moment in our life happens every single day. We don't have time to talk about it. We just throw it on our back and keep going." End of quote. And with that, We are identical twin sisters that are aware of those relations as experience daily sexual, physical, and emotional abuse at the age of 5 years old. This is us at 5. It's difficult to grasp that we would continue to endure multiple times a day, every day, for over the next 10 years, at least 8,000 acts of violence on our bodies at such young ages. To put a number on it seems an out-of-mind body experience, but helps others to grasp the gravity of violence we had to endure. We learned as children not only how to disguise our true emotions, but coping mechanisms to endure the extensive amount of abuse and minimize the pain. When our father placed a loaded gun against my head as a reminder of what he would do if we exposed the abuse, from my perspective, that was a really good day, because it meant in that moment I was not being sexually abused, or my life would end and the daily torment would end as well. My identical twin sister and I were born and raised in Baltimore and lived in a disturbingly abusive household. The dichotomy that existed for us was having a very loving and compassionate mother and a stay-at-home father that severely tormented my sister and I every day. Our incredible mother, who's our best friend to this day, solely bore the financial responsibilities for the family due to one of many roles as she was attending one of the top universities in the country while working a corporate job. It was in her absence that the severe torment would ensue. This trauma was unbeknownst to her, and our lives, including the life of our mother, was threatened by our father if we told anyone, which included our mother. So we kept the abuse a secret out of fear of deadly repercussions, and that secret would eventually begin to unravel our lives. There's a number I think of often. 1 billion children worldwide experience abuse every year, and many of those that survive their childhood face negative manifestations that show up as chronic illnesses, obesity, chronic pain, depression, and adulthood. My sister and I are 2 of them. As my sister mentioned, we were beaten or sexually abused or emotionally abused every day for over 10 years. And we say 5 years old because 5 is the earliest we can remember the abuse beginning. At 9 years old, our father tried to rape me, and that's still very tough to say at 47 years old. I had a lot of suicidal ideation as a child, and the only reason why I didn't commit suicide is because I didn't want to leave my sister alone in the abuse. I'm so grateful for the woman next to me. I would not be here without her. We had some positive coping mechanisms, our sisterhood first and foremost, our love of reading and writing, music, being creative. But we also had a very negative one, which was seeking solace in the types of foods that destroy your metabolic system. That coping mechanism would become a full-blown addiction in our teenage years and adulthood. It would cause severe chronic illnesses, chronic pain daily, depression, temporary blindness in our 30s and 40s, and also depression. I was incessantly seeking solace in refined sugar and ultra-processed food. No one ever seeks solace in vegetables. No one's ever emotionally eating with broccoli. We're emotionally eating with pizza and donuts and cake and candy. But I just called it being a foodie. Come on, being addicted to refined sugar and UPF, those are not real addictions. But my constant consumption of these types of foods caused 112 pounds weight gain, which caused daily debilitating pain. I also was hypertensive, pre-diabetic, fibroids, sleep apnea, and depression, which arose as a result of the way I was eating, all of which I ignored. And none of these severe illnesses were enough to persuade me to change the way I ate. Nothing. And I never thought my food consumption was an addiction, but when you're doing something that's wreaking havoc on your body and you're unable to stop, I think that qualifies as an addiction. And nothing helped, nothing. And as much as I tried and tried and tried over the years, nothing worked. Until 16 months ago, I had my first session with Ibogaine at a medically staffed center in Mexico called Beyond. Medicinal plants like ibogaine, an African shrub native to Central Africa, unequivocally helped change the trajectory of my life. But to put some context on why I classified all my mind-altering drugs as simply drugs stemmed from childhood influences. Our biological father suffered from a past addiction to heroin, but was able to overcome that addiction before he married our mother. And because of his own history with heroin, he was adamant that his daughters would not experience the same. Therefore, we grew up in a household where there was zero tolerance for narcotics. So as a woman who was adamant against any kind of drug use due to our father's history with addiction, I was against all drugs of any kind unless in an ICU or any other medical emergency. I had to take a step back and admit how truly little I knew about psychoactive plants in the field of helping to heal PTSD, addiction, depression, OCD, and anxiety, all of which we suffered from. It was through my own experiences, the research, and the stories like the ones you're hearing today that changed my perspective. These psychoactive plants helped me to become conscious of decades of subconscious detrimental habits, thought patterns that I was able to later change through neuroplasticity of these medicines, integration, future self-work with psychoactive plants in a safe set and experience setting. This new perspective changed the way I not only felt about medicinal plants, but the name in which I called them. I re-educated myself and began to reclassify the language around psychedelics, referring to them as medicines versus drugs. I began to promote the narrative of rescheduling these medicines as therapeutic due to its non-addictive properties and undeniable beneficial scientific research. Along with my own personal experiences in treating addiction, OCD, PTSD, depression, and anxiety, which has changed my aforementioned views. Though like with any medicine, there can be side effects. And even when administered correctly in the right setting and or if pre-existing conditions, medical history are not known or disclosed, ibogaine can cause a prolonged QT interval, which means the lower chambers of the heart take longer to recover after each beat. But the risk is low. And if monitored with a fully experienced medical team, the effect can be reversed instantly. We had our own experience with ibogaine at an ibogaine treatment center in Cancun, Mexico called Beyond. And beyond the cultural awareness and respect of the community that cultivates this plant for many Westerners to use, the level of professionalism, safety, care that the team at Beyond facilitates to each and every client is evident. I personally would prefer and recommend ibogaine administered, excuse me, in the way that we experienced with physician and nurse care through the entire 12-hour experience. Our experience was 12 hours, as well as round-the-clock care. The experience also included electrolyte, IV hydration, blood pressure monitor, EKG readings, and sessions with psychedelic therapists. And the experience with ibogaine also helped me to discover how to manage and reduce my chronic stress-related hypertension due to our childhood trauma. I had two very strong epiphanies after my ibogaine session. One, I was the unhealthiest I'd ever been in my life. The healthiest and heaviest I'd been in my life, but it was the lightest I'd ever felt in my life. Two, my body was so acclimated to abuse as a child that I didn't recognize I had become my own perpetrator, continuing to perpetuate this abuse upon myself through my food consumption because abuse was my norm. It was all I knew. And for the first time after my ibogaine session in 4 decades, I didn't have a single craving for sugar. I left Beyond in Mexico. I went home. I did the work. I eliminated ultra-processed food and refined sugar for a year. After that, my consumption of it has drastically decreased as I am intent on improving my health. I started walking 20,000 steps 6 times a week, strength training 3 to 4 times a week. All my chronic diseases vanished or drastically lowered in severity. I lost naturally 80 pounds of my 112 pounds weight gain that caused debilitating pain. And that debilitating pain also vanished as well. Now my relationship with food is much, much healthier. A renowned trauma expert, Dr. Gabor Mate, states, quote, "The greatest damage done by neglect, trauma, or emotional loss is not the immediate pain they inflict, but the long-term distortions they induce in a way a developing child will continue to interpret the world and her or his situation in it. Unwittingly, we write the story of our future from narratives based on the past. Mindful awareness can bring into consciousness those hidden past-based perspectives so that they no longer frame our worldview. Choice begins the moment you disidentify from the mind and its conditioned patterns, the moment you become present. Until you reach that point, you're unconscious. In present awareness, we are liberated from the past." End of quote. In short, trauma is not the experience itself, but how we react and see the world in your present due to traumatic experiences of the past. And trauma addiction is also a way to cope, which shows an incredible sign of strength and ways to feel better or survive. But many times those coping mechanisms, whether it be opiates, overconsumption of alcohol, or ultra-processed foods, is detrimental to the mind, body, and soul. If you're not aware of why you're addicted, you can't change what you're not aware of. Working with psychedelics like Ibogaine helped me to become very aware. It helped me to become very present so I could change what was no longer serving me. Ibogaine also helped me to realize what I continuously needed to change is not to live in a fight or flight patterns and not respond to the world from childhood trauma, colored glasses. Now, my sister and I, our story are different from the ones you hear today. Our addiction is different from what you may hear. But I think the common thread for many people that experience trauma is that they feel that they've hit rock bottom. And I don't know what's further than hitting rock bottom, but I was definitely on my way to it. However, Ibogaine makes digging out of that rock bottom possible. It makes digging out of that rock bottom a whole lot easier. And I immediately started digging 12 hours after my session with Ibogaine. Many people can resonate about being on the fence when it comes to psychedelics. I was one of those people. I believe they were just like equivalent to heroin or cocaine. As my sister mentioned, we were raised not to do drugs. I was adamantly against them, absolutely resolute in not trying them, until I became more and more open to the loving and steadfast encouragement of my sister, who's been working with psychedelics in a healing capacity, along with integrative practices for almost 9 years. Over the years, she encouraged me to change my health and healing. I watched her soar even higher when she used Ibogaine with her health and healing. We experienced nearly identical trauma as identical twins with identical coping mechanisms that evolved into identical addictions, and she was able to soar in a way that I could not. I'm always so proud of her, but I was incredibly disappointed in myself at that time. Ibogaine gave me the chance to soar next to my sister instead of looking up at her from below, wondering why I couldn't fly. I have and always will be incredibly proud of my sister. But the major difference in our healing journeys was one was able to propel past our childhood trauma due to the assistance of psychoactive plants, medicines like Ibogaine, while the other did not due to non-use of psychoactive medicines, which is why I just wanted to mention, I think it's really important to mention, it's called the ACE test. I'm not sure if anyone has heard of it, maybe many of you have. ACE stands for Adverse Childhood Experiences. The ACE test is based on the ACE study conducted by Kaiser Permanente and the CDC. The test is separated into 3 categories of 10 childhood adverse experiences. Category 1 is childhood abuse, including sexual, physical, and mental. Category 2 is neglect, includes physical and emotional. And category 3 is environmental challenges, including domestic violence of one or both caregivers, raised in a household with substance abuse, divorce, incarcerated family member, and/or mental illness. The ACE score ranges from 0 to 10 based on the 10 types of childhood adverse experiences. In the ACE study, respondents were given an ACE score between 0 to 10 based on how many of the 10 types of adverse experiences they reported experiencing. So in short, just a generalized marker for childhood survivors and understanding the nuances of childhood trauma and how it can debilitate your life. According to the study, the higher your ACE tally, the higher risk you will suffer from medical and psychological ailments. An ACE score of 4 or higher increases the chances of depression by 460% and attempted suicide by 1,220%. With that being said, I thought it was really important to mention that because I wanted to give you a scope of the amount of childhood trauma we endured as we each scored a total of 9 from the 10 types of adverse experiences. But despite what we endured, we are overcoming, pushing through, healing from physical and mental adversities while breaking the chains of intergenerational trauma. What we faced as children was severe, but sadly not uncommon. I wholeheartedly believe it is due to the unwavering support of my wonderful sister, family, loved ones, communities that are aligned in healing trauma, working with medicinal plants like ibogaine in a safe setting accompanied by the experienced facilitators and treatment centers, as well as daily integration. You'll often hear that ibogaine isn't a magic pill, but it feels quite magical in the way that it shifts your mind. You hear a lot of talk about reset, and that's what it definitely feels like. It felt like a reset, feeling like these foods no longer had a hold over me, feeling like I could say no to them. It felt like liberation, unlike anything I had ever experienced. After my ibogaine session, I simply said, I'm no longer eating this way. I am no longer eating this way. Ooh, the countless times I've said that over the years, well, that declaration could fill the Hoover Dam. I always gave in to the cookies and the cake and the pizza, no matter the state of my health. But not this time with ibogaine. I knew that I immediately meant it. Overcoming a 40-year addiction to ultra-processed food and refined sugar felt easy. It was easy. I had one session with this medicinal plant, and I committed to no longer eating this way for 1 year. I wanted to rehabilitate my body to give it a chance to heal itself. So I committed to no longer eating that way, and I rehabilitated myself by eating whole foods and moving my body a lot more. Did I relapse during that year? No, not once. Did I have a sugar craving? Oh yeah, once. I had an urge to order a dozen donuts 4 months after my session. I called my sister, I went on a walk, and the craving disappeared. In the past, I would have not called this best friend next to me. I would have called my 2 other best friends, Uber Eats and DoorDash. But I did not give in to the craving. I leaned into my healthy habits, and I pushed past the sugar craving. Now my relationship with food is drastically different. I don't overconsume it in one sitting. In the past, my moderation was disguised as overconsumption because I was unwilling to truly be honest with myself. When I say I want to treat myself, I look at that differently now. I say, yes, I should be treating myself all the time with healthy food. Because am I really treating myself if I'm treating myself with food that treats my body badly? Answering that question truthfully, gaining this new perspective on life has saved me from a future of preventable diseases that cause death And I know Mississippi has one of the highest rates of preventable diseases that cause death, and that really resonated with me. I was on that path until Ibogaine steered me on a new one, a path where I realized I no longer had to hold on to a coping mechanism that helped us survive as children, besides our sisterhood, but was destroying me as an adult. Through these psychoactive plant experiences, I discovered I'm much more than an accumulation of horrific acts. I'm much more than that. And yes, I was sexually assaulted every day of my life for over a decade, but it is not who I am. It does not have to consume my present and future, and it does not define my life. I do not have to live my life in fight or flight and cope in ways that are not beneficial for my mind, body, and soul. I'm not here to tell you that my trauma is more significant than your trauma, because that is not how pain works. All experiences are significant depending on the person's perception, and from that perception, something could be monumentally tragic to you, but not to another. Regardless how we feel and process pain is often the same, and no matter what your story is, that similarity is what bonds us. We should not be suffering, and we should not be suffering alone. We can talk about prevention and potential preventative solutions, but what is going to be done for those who are in need of help today? Not sometime in the future, but now. According to the CDC in 2023, there were approximately 287 deaths per day from opiate use, 287 deaths per day. The crisis is real, and we need to be open and finding different resources that have tremendous power in changing the neuroplasticity of the brain to help overcome addictive behaviors, reset habits. And Ibogaine should be considered as part of the solution. The research, clinical studies, and individual personal accounts of working with psychoactive plants needs to be continuously shared as transparency and open dialogue. Release of fear and stigmas is key in solidifying the efficacy of Ibogaine. I believe medicinal plants like Ibogaine in a safe set and setting, along with integration, gave me the opportunity to continue to just hold on until I was strong enough to process the pain and truly begin to heal and return, transforming my life. As a woman who has experienced child abuse for over a decade, every single day, from 5 years old to 16 years old, and during that time often thought about ending my life, a memory I will never forget is of myself at 9 years old, sitting on the floor of my bathroom, utterly in despair. Another act of sexual abuse, thinking, this can't be it, this can't be it, this can't be it, to life. Somehow, innately within me, I knew there was something more than just suffering. There's much more to life than to suffer. There's much more life than constant pain. There's much more to life than just this moment. And if you keep holding on and do the work to truly heal and take consistent agency, the most beautiful transformations await you. Yeah. And I'm just ending with this. Out of all of our accomplishments, whether being featured in Vogue's documentary as one of 6 brilliant women, TED Talk speakers for the New York Times, and campaigns for Valentino, Fendi, Tiffany & Co., and Bulgari, opening up for Sting, Erykah Badu, Nas, and Queens of the Stone Age, invited to the White House for creating more inclusion and diversity within the fashion and beauty industry, being the first 2 Black American sisters on the cover of Harper's Bazaar, Netherlands, or animated into princesses by Disney. We consider this to be one of our biggest accomplishments in being able to share our story with all of you today. I know firsthand what it's like to see what your loved one, I know what it's like to see your loved one suffer. I know what it's like to witness a loved one transform. And I think so many of us deserve to see life-altering transformations, not only in ourselves, but also in the ones we love who may be struggling right now. And ibogaine, along with integration, may be the answer in helping those transformations become a reality. I never thought I would be sharing my story, and I never thought I'd be sharing it in this way, especially especially sharing my story with all of you and not feeling any shame about being a sexually abused survivor. But it's my honor to be here and hopefully help to open some minds. And I want to thank you so much for your time, and I want to thank you so much for having the compassion to listen to all of our stories.
I know with certainty that I wouldn't be standing here in front of you without this beautiful woman next to me. I'm eternally grateful for her story and her work with psychedelics and healing. She, our sisterhood, and a plant from Africa saved my life. Lastly, we'll end on this. As much as the science is imperative to this conversation, I really believe that it's the stories that will open the hearts and minds. And I hope by the end of this hearing, your minds and hearts will be opened even further to the life-changing treatment ibogaine can provide to so many survivors and veterans who need your help right now. Again, thank you so much for your time and for listening.
Ladies,
Thank you.
thank y'all very much. Your courage to tell your story today gives meaning to why we're here. So we appreciate you being here. And when you give this speech again, you can add coming to the Mississippi Capitol and testifying on behalf of ibogaine. So thank you.
Thank you.
All right, Mr. Hubbard, you're between us and a healthy lunch. I'm sorry.
Mr. Chairman, I want to apologize to the sisters for not offering a almond bucket or a vegetable plate. I know there are donuts and banana bread back there, so I'm sorry. Sorry we didn't have anything else.
We'll have you back for sure. All right, next we have Brian Hubbard, CEO of Americans for Ibogaine. Mr. Hubbard, bring it home.
Out of tremendous trauma and tragedy has emerged this gallery of immense wisdom and beauty. And thank each of you for bearing your heart and soul before this committee and before the world this morning and afternoon. My name is Brian Hubbard. I am currently the Chief Executive Officer of Americans for Ibogaine, an organization founded by the Chairman of the Board, Governor Rick Perry. I was born and raised in the coal fields of Virginia in a working class family. And like many folks raised in those circumstances, I was taught that the measures of achievement were to go to medical school or to go to law school. And because I couldn't do very well in math or science, but could talk and write a little bit, ended up going to law school. I attended the University of Kentucky and graduated in the year 2000 and had a very accidental legal career, practicing law 16 years statewide, representing Walmart, Tennessee Valley Authority, and Tyson Foods exclusively in their workers' compensation litigation at a time that coincided with the onset and explosion of the opioid epidemic out of central and southern Appalachia, out across the rest of the country. After 16 years in litigation practice, through a happenstance connection to an expert that I had utilized in my caseload, I was recruited and asked to run Kentucky's Social Security disability system by then Kentucky Governor Matt Bevin. I was tasked with the job of understanding why it was that Kentucky was second only to West Virginia for as long as anyone could remember in terms of the percentage of our people who are on Social Security disability benefits for a lifetime, or what is called back home, getting the check. In addition to the Social Security Disability System, I came to run the Child Support Enforcement System. At the end of the Bevan administration, I went to work for the Kentucky Attorney General, then Daniel Cameron, who recruited me to run the state's Office of Medicaid Fraud and Abuse Control, a law enforcement agency that has as its responsibility the investigation and prosecution of medical providers for fraud on that system, as well as the investigation and prosecution of any provider who engages in the neglect or exploitation of a Medicaid beneficiary. Because of a record that had been compiled as a no-nonsense, get-it-done with transparency public servant, I was recruited to run Kentucky's Opioid Abatement Advisory Commission, established by our state's legislature in 2021 to administer what was then anticipated to be approximately $1 billion in settlement funds that would be obtained through a multi-state litigation process from opioid manufacturers and distributors for their role in the creation and perpetuation of the opioid epidemic. When I was asked if I had any interest in the job, I observed that Kentucky, along with Louisiana, jockey for top of the line when it comes to systematic political corruption, and that this was a very treacherous opportunity that could very well land the state as the subject of a Frontline documentary sometime down the road. I advised the office that if they were willing to let me run the commission in a way that was accessible to everyday individuals and organizations working on the front lines of the opioid epidemic who had usually been walled off from the opportunity to secure these funds, that they allow me to run it transparently so that the people of Kentucky would see where every dime of this money would be spent, and to do so in a way that made us accessible and accountable to everyday Kentuckians, that I would take the job. I was interviewed and asked to define what the commission's priorities needed to be, recognizing that $800 million represented approximately 8 months worth of net sales of OxyContin by Purdue Pharma. $800 million that would be paid to our state over 15 years. I recognize that while $800 million was a lot of money to the regular everyday ear, it is in fact crumbs from the tables of gluttons. Because this would be non-recurring revenue, I said that we needed to focus on developing a therapeutic breakthrough for opioid dependency. Despite the very best of intentions and the deployment of what has now been hundreds of billions of dollars in public resources, the very best of our treatment options have about a 25% success rate, which means 3 out of 4 times they fail. The neurochemistry of opioid dependency means that for the opioid dependent individual, they cannot produce their own dopamine or serotonin. These are our human survival chemicals, which drive all of our most baseline instinctive behaviors. Those being fight, flight, eat, drink, and procreate. So when the opioid dependent individual engages in what appears to be morally depraved behavior, what we are actually seeing is the result of a profound neurochemical brain injury by which the brain is starved for dopamine and serotonin in the absence of ever-escalating dosages of opioids. I came to learn that this quixotic and outlandish sounding molecule called ibogaine had the unique capacity within 36 to 48 hours to physiologically resolve opioid withdrawal syndrome with a single treatment for 80% of people who receive it. And it does so by restoring the brain's dopamine and serotonin production to that which existed before the person ever engaged in substance use, no matter how long or how much of those substances they had consumed. And so I proposed on May 31, 2023, on the grounds of the Kentucky State Capitol, that the Kentucky Opioid Commission would explore the possibility of devoting $42 million or 5% of the state settlement funds to the creation of a public-private partnership which would see ibogaine through the FDA's approval process as a breakthrough therapeutic for opioid dependency as well as co-occurring substance use dependency. It is important to note, and one question was asked earlier, why this hasn't been done by venture capital or the pharmaceutical industry. And we can get into a little bit of this later in what I hope will be a very vigorous question and answer session. The bottom line is that the patentability of ibogaine as a treatment for opioid use disorder expired in the early 90s. So if we are going to do this to address the gravest engineered humanitarian catastrophe to fall on our society since the end of the 19th century, it is going to require the incentivization of the public dollar on behalf of the people to help make it a reality. Because of the institutional capture of Kentucky state government by the opioid maintenance industry, which is the opioid industry itself, the project was killed with malice in December of 2023. I then went to work for a nonprofit foundation called the Reed Foundation out of Columbus, Ohio, whose founder, Rex Elsass, lost his son Reed to a fentanyl overdose at the age of 26 after this young man had struggled with opioid addiction for a decade. I was desperate to preserve the work that had begun in Kentucky, which included the commitment of high-level philanthropists to partner with the state, in addition to the commitment from potential drug developers to anchor their research, development, and manufacturing within the state. Rex said, "The work you have done is important, and I will do whatever I can to keep it alive." Over the next 8 months, there was a desperate mission pursued in the states of Ohio for months, then South Dakota, to find a place where this project could receive the hospitable reception and thoughtful consideration that it deserved and take root and grow. The rest you now know. On June 9, 2025, Governor Greg Abbott of the great state of Texas signed the single largest psychedelic research and medical development appropriation in all history, and the first project to be initiated by a U.S. state to fund drug development to address existential public health crises within its borders, which are representative of those that are impacting our country across the board. On December 14, 1995, the FDA approved Purdue Pharma's OxyContin for the, quote, management of moderate to severe pain. It was then promptly detonated in the southern Appalachian coal fields from which I come. America has lost 509,942 service members in combat during World War I, World War II, Korea, Vietnam, and the post-9/11 wars. Conflicts fought over the course of 44 years. Over the last 30 years, more than 600,000 Americans have died from opioid-related overdoses. In 2015, Princeton economists Ann Case and Augustine coined the phrase deaths of despair to capture the alarming rise of premature mortality among Americans due to drug overdose, suicide, alcohol-related disease, all preventable deaths. Over the past 10 years, 1.5 million Americans have died these deaths of despair, a casualty figure which exceeds the total number of U.S. service members lost to all war throughout the entirety of American history. Right now, the United States, land of the free, home of the brave, has 102 counties with populations which have life expectancies less than that of North Korea. Some of those are in the coal mountains of East Kentucky, and some of those are right here in the Delta of Mississippi. The last 24 years of unmerciful military conflict has taken exponentially more service member lives by suicide here at home than have been lost on battlefields abroad. In Mississippi, 70% of all overdose deaths are related to opioids. In 2023, emergency responders administered naloxone, a life-saving and vital anti-overdose drug, 3,084 times, an average of 8 opioid overdose reversals every single day. Also in 2023, and I must acknowledge, coming from Kentucky, this is disturbingly familiar. 77% of Mississippians filled at least one opioid prescription. That's 2.27 million prescriptions and more than 118 million pills. 39 pills for every man, woman, and child in this state. The American opioid epidemic, now in its 30th year, costs us more than $1.5 trillion annually. Its cumulative cost since the turn of the century is over $10 trillion. Our most recent annual federal budget deficit was $1.8 trillion, and our total national debt stands at $36 trillion. I think many of us in this room, as well as outside these walls, recognize that we are in the middle of an existential struggle for the survival of this country. We are the inheritors of the most beautifully dynamic, multicultural society to ever exist in human history. Despite all of our material wealth and technological prowess, we are living in a brutally dehumanizing era that is hostile to individual identity. Today's citizens are fungible revenue units who are plugged into a set of actuarial variables that are designed to reduce their lives to reasonably predictable funding streams. Massive governmental systems have enthroned themselves on the helplessness of powerless people. They commodify problems they are supposed to solve by monetizing sustained human misery. Government must be made to function honestly, accountably, and responsibly to the genuine needs of the American people, or else our society will inevitably collapse beneath the enormity of its corrupt decrepitude. Like my Kentucky home, Mississippi is a beautiful place populated by beautiful people. It is also home to a host of generational pathologies which produce common afflictions among diverse populations. Let me begin by saying that I am proud to be from the South of the South, always. But for as long as it has existed, the aristocracy of the South has sought to impose and perpetuate the political, economic, and spiritual subjugation of poor and working class Black folks, right along with poor and working class white folks. In 1929, my Papa Hubbard began working in Virginia's coal mines at the age of 16, a time at which a mule or a piece of equipment was more valuable than men. A company had to pay to replace equipment or a mule, but you could replace men for free. They were captives of coal camp feudalism. The company owned them, their families, and the law. when Papal and the miners of his era turned to the United Mine Workers of America to fight for their dignity. The coal companies came to the Mississippi Delta and recruited the black sharecropper to replace and evict the white coal miner. The companies banked and bet on the desperation of the black sharecropper and the generational wicked despotism of white racism to kill any unified challenge to their malignant greed. These poor men, with almost no formal education, recognized that the dividend of division is control. They may have been black and white, separate and apart, walking into those mines, but they were all black together walking out. These are the visceral roots of our current affliction. The redemptive beauty of a sacred plant from West Africa helping heal the descendants of the sharecropper and the coal miner together illustrates the racial unity we must have if we are to prevail against the pathos of our age. Racial unity which recognizes and exalts our kinship as images of an eternal creator whose essence is almighty, unconditional love for each and all of us. At the heart of trauma and addiction is profound spiritual affliction. It is my prayer that Mississippi will join mighty Texas and turn the fulcrum of history toward the primacy of the human soul. Abigail Hills, thank you for your time and thoughtful attention. May God bless Mississippi.
Thank you, Mr. Hubbard. Thank you so much. It's 10 till 1. We'll allow at least 10 minutes for questions if we have it, and I do have a few. As far as the partnership with Texas, and work under one FDA trial application, is that true?
That is correct.
And then you mentioned the poor state of Mississippi, and we are one of the poorest states, if not the poorest in the country. $5 million from perhaps the opioid settlement statement or general funds or wherever, that's a big ask for us. But in your opinion, which I think I know what it is, but is that money well spent for the state of Mississippi?
Mr. Chairman, the state of Mississippi is a vital and integral partner, potential partner for the state of Texas. The objective here is to develop ibogaine as expeditiously and efficiently as possible through the creation of a single unified FDA trial that will involve multiple states across the country. These trials must be geographically and demographically diverse. And because of Mississippi's unique composition, geographically and culturally and racially, it fits the bill. And $5 million, perhaps even matched by another $5 million, would see hundreds of Mississippians receive the treatment for the condition it's being developed for.
My understanding is that the Texas bill, the pharmaceutical company that they choose has to match the 50 million.
That is correct.
And so that pharmaceutical, we put up 5, if we put up 7, they would match that as well.
That would be the hope and objective. Yes, sir.
All right. And so the pharmaceutical company, the state of Mississippi, would also need to partner with an institution, a hospital or a clinic, to conduct the trials.
Yes, sir. Mississippi's appropriation would pay Mississippi facilities to provide ibogaine treatment to Mississippi residents in partnership with Texas within the framework of a single unified FDA trial. One other point that I would make, because Americans for Ibogaine has uniquely situated itself as the premier public policy and advocacy organization that is the architect of the Texas plan that is going to play out across the rest of the country, I can affirm for members of this committee that we are in regular communication with the leadership of the Health and Human Services Department of the federal government, that this is a project of immense importance given the prioritization of psychedelic research and medical development by the new FDA Commissioner, Dr. Marty Markary, and we anticipate and aim to create the unstoppable external force through the multi-state coalition to crash through the federal walls to make the reforms necessary to bring this into medical reality.
If this is successful and is able to be commercialized, is there a windfall for Texas or the state of Mississippi?
Mr. Chairman, I would not necessarily describe it as a windfall. What I would describe is an opportunity for states to see a return on their investment for this project that they are currently not receiving on the hundreds of millions of dollars being spent with no return on what we have. So for instance, the state of Texas is demanding within the statute that the drug developer propose a recognition of its commercialization interest in everything that comes out of this project. The people, which means the states, need to be treated as equity owners of this project so that the benefits will accrue to their citizens directly by advanced and priority access to treatment, while also seeing perpetual return on monetary investment because these problems are part of the human condition and they're never going away. And what we can quantify is that a substantial portion of that $1.5 trillion figure just for opioid addiction goes for the administration of treatment. I will use Kentucky's figure as an example. Those figures that you saw Mr. Lawrence display regarding state Medicaid, those came from my Office of Medicaid Fraud and Abuse Control, where we performed this analysis. Between January 1 of 17 and October 31 of 2023, Kentucky Medicaid, covering 1.6 million individuals, paid for over 110 million doses of Suboxone and had been billed over $1 billion by the manufacturer of that medication for that dosage statewide. While Ibogaine is not going to yield that sort of return on investment because of the way in which it has the ability to deliver curative effects, it will deliver ROI in perpetuity that will return investment to the state through the direct administration of treatment. And I think as we get out here and understand what I would quote a researcher as a recognition, that this is the most sophisticated molecule on the planet. And while the front side will be for the development of opioid use and co-occurring substance use disorder, we are going to pioneer a number of advanced neuropharmacological breakthroughs that will make each individual state participant a research center of excellence for all of the advanced applications we will find this can bring.
Questions? Senator Harkins. Oh, Senator Wiggins, sorry.
Thank you. I leaned over to Senator Harkins. I said, now that's a closing argument. So from one lawyer to another. So if I understand what Texas did and what y'all are asking us to do is create this public-private partnership for clinical trials. And by definition, clinical trials are to see if the program basically works. And understanding the personal testimonies that we've heard, the clinical trials are basically a scientific way to see that happen. But that also means it could result in being proven not effective or at least not scientific. Have y'all thought about that? And as the chairman said, it's a lot of money. What's your thoughts on that being the case?
Well, the FDA's drug development process occurs in phases for the very reasons that you have articulated. Phase 1 is the safety and efficacy phase. Phase one is actually the safety phase. You move into phase two where you deliver the medication to healthy human subjects, and then you move into phase three to measure both safety and efficacy. If at any point in time we discover that the thousands of known cases of restorative outcomes are not matchable within the FDA's drug development framework, the opportunity exists to cut off participation and spend no more. It is not an irrevocable perpetual commitment once that money is deployed. If at any time you reach a stage gate where failure appears to be inevitable, you don't resource the funds any further. And I would say anything that beats a 25% success rate, I believe is going to be progress.
Worth investing further down the line?
Well, based on the radiographic evidence that has been shared through these functional MRIs, we can assert with certainty there is no known medication within the Western medical system that restores brain tissue. There are things that can create incidental neural connections here and there. Nothing that is restorative. Nothing that takes the black marks of dead brain tissue from traumatic brain injury and erases them. There are profound neuroregenerative properties within this medication that are going to change the lives of millions of people. So even if it doesn't have the efficacy as it relates to opioid dependency that we hope, we are going to create a number of breakthroughs for the symptomatic treatment of conditions for which we have no current effective long-term treatments. That's the worst you're going to do. Thank you.
Mr. Hubbard, I would assume going forward, if we agree to this and we invest $5 million next year, then it'd be another $5 million every year thereafter? Or is that what Texas's plan is?
I would never presume to speak for the leadership of Texas, but based on the experience that I have there, they're committed to one thing, and that's getting the job done. So I believe that if this works as we think that it will, they're going to see it through. If they go through that first 50, assuming it's working, they're going to keep going until we get the job done. And we hope the state partners will be right along there with them.
Senator Frazier, we see you got your camera on. Did you have a question? No questions? Gentleman from DeSoto.
Thank you, Mr. Chairman. Thank you, Mr. Hubbard, for being here. And thank you for your passion to see people bettered. But in all this discussion about investments and ROI and who will benefit if something comes out of it, it begs the question, and I do have to ask, does Americans for Ibogaine or anybody on the board stand to receive financial benefit should that happen as well?
I'm going to answer you point blank on that, sir. You heard the jobs that I had in Kentucky. And the reason that I had them was because I operate like this and sometimes like that, but it's not this way. You know what I'm saying? So in Governor Perry and my estimation, this is a divinely appointed mission. And the surest way for us to implode this opportunity is to taint it with the creation of present or future anticipated financial benefit on the backside for what we're here to advocate on the front side. I would not be fully honest with you if I did not acknowledge through this process beginning in Kentucky in the late fall of 2022 that I had not received gestures of generosity that were aimed at tilting the table in one direction or another. All of those have been vigorously and assiduously rejected. And as for myself and Governor Perry, who at the age of, he's 75 years old and he was reported in the New York Times. There is no incentive for him to tank this project based on where he now is in life. And I can personally tell you, having come out of the hard hollow, I'll go back there and die for before I fail this mission with the sort of corruption you're referencing.
Well, I appreciate that. And I was in no ways trying to insinuate anything, but we do live in a day and age where in Big Pharma, we're talking about Big Pharma, the previous speakers were talking about. And so just wanted to make sure that everything was on the up and up.
You've articulated what has consistently been my greatest articulated concern. Because of the way in which the standard operating practice within public life is to create a ruse for personal gain, the last thing that I would want is for these individuals to be associated with what one would impugn as an industry-sponsored front to create a new economy that personally benefits Brian Hubbard.
Thank you.
Yes, sir.
If no, there's no other questions, I'd just like to close with, it is truly from everyone in this public health committees, both House and Senate, truly appreciate the heartfelt testimonies and the service that y'all have done for our country and for our state. And we truly appreciate you sharing your stories with us. Mr. Hubbard, thank you for your testimony and your passion for this. And it's truly our mission to bring help and healthy treatments to the people in Mississippi. And so we thank you for your testimony. We thank everyone for attending, and our public health members, thank you all for enduring this. I know we plowed through, but I think it's very important. And if anything, it leaves us that we have much more work to be done and many serious conversations to have for the state of Mississippi. Thank you for being here.
It's an honor and a privilege. Thank you all for your hospitality.